jump through all these hoops that have been thrown in front of you, but you've all done well just to get to this point. I can see the background. You've got the background in place, which is fantastic. I know you've all sent in your recorded Zoom presentations that will stream live shortly. Just wanted to let you know how things are going to work. I've also got the discussants for each paper online and the judges as well. The way it's going to work, I think I've briefed most everybody on how it's going to work, but I'll just let you know again. What will happen is I will introduce each paper and each presenter live. The tech team in India will then live stream your recorded Zoom presentation of your paper. Each of those we know is in place. We know it's 9 minutes. And that's fantastic. At the end of your presentation, I will come back on the screen live, as will you, the presenter who's presented that paper, and the discussant will come on live. And I've sent those lists through to the tech support team in India. So hopefully this will all be relatively seamless. Once the paper is finished being presented, and the discussant comes online, I will introduce the discussant, and then the discussant will have a minute or so to ask questions of the presenter, and those questions will be asked live. At the end of those questions, the presenter, who is again going to be on live, should then respond to those questions. If we have any questions from the audience, Mrs. Paltridge is going to be monitoring the Q&A box, and if any questions come through on there, she will feed them through and ask them of you, and if you would please respond to those as well. The Q&A for each paper will only go on for a couple of minutes at most, and then we will move on to the next paper. Does everybody understand how that's going to work? Do you have any questions about that process? No?
Just one thing more, Scott, just to add the
Yes.
tech side.
Yes.
Whenever you are a discussant or you are a presenter, when you're asked, kindly open your cameras and also only then unmute yourself. Rest of the time, kindly keep yourself muted, because any disturbance right away can be heard in the hall. You're all on stage. Just imagine that you're on the stage with the microphone on. So kindly mute it. And when you're a discussant, kindly open your camera, because only then you will be visible to the people in the hall. So these two things. Rest of the time, please, you can keep your camera on, off, whatever you can do. But at least when you're talking and when you're discussing things, and also the participants and the presenters, when they're asked questions, please open your camera and unmute yourself. Rest of the time, kindly keep yourself muted. That's it from my side.
Yes, I think that's a really important point. As we all know on Zoom, if your mic is left on, everyone does hear it. So any other questions from presenters or discussants or judges?
No, I think when everybody has joined, we can start.
Yes, I think we're ready. Did we get? Oh, sorry, are you still there? Did we get Dr. Narelin online?
Not yet, but I asked the team to call her. I think she will come by the time that her turn to be present.
Okay. All right. Very good. Thank you very much, Asari, for chasing that up. I think, Amit, we're ready to go. So anytime you want to put us live, I can then introduce us and get things underway. We just to go over the order of presenters. There was a slight abnormality in the printed program, I think, that Amit sent out, which had the Indian paper at the end. The Indian paper is actually number 5 on the presentation roster. And the final paper will be the Sri Lankan paper presented by Randil Dialwas. Is that correct?
Right. Okay. Right. That's correct. That's right, the order. So the tech team, you just give us the count of 10 and tell us when we are live. The tech team, you can make us live now and give us a count of 10.
Okay, sir. Okay, we are going live in 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We are live now.
Hello, everybody. I'd like to welcome everybody that's been waiting patiently for the residence paper competition for the Region 16 virtual meeting this year. I'd first of all like to thank very much Dr. Amit Gupta and Dr. Professor Mahesh Misra and his team in India for supporting this virtual Congress. They have done a lot of work in the background to try and make this a success. And I'm delighted to again chair the residence paper competition for this year. Many people and many countries within the region have been able to enter papers, and I'm delighted that there are so many that we have this year. In fact, this year we have more than we did last year. So I think that's a wonderful demonstration of the continued growth within the region. So thank you for everybody for attending. We do have 8 papers to present today. And the way we'll conduct it is very similar to the way the American College of Surgeons Committee on Trauma Residence paper competition that's held in the northern spring each year. It's very similar to the way that competition is held. I'm of course delighted again that whoever wins this competition will be supported by the American College of Surgeons to potentially attend that meeting if it's held live. Last year and earlier this year, the meeting was held virtually, but I think the plans at this point are to go ahead with the COT meeting in March of 2022 in Seattle, Washington. So hopefully, pandemic and travel permits and all those things pending, whoever wins this competition will be able to travel to that meeting. And if not, they'll be able to present virtually. I think we will begin and get underway with our first paper. And our first paper is going to be presented by Dr. Gauri Chakraborty from Bangladesh. And the title of the paper is The Social Aspect of Physical Assault and Interim Analysis. Welcome, Dr. Chakraborty. We look forward to your presentation.
Can we start the recording of the presentation? One.
Good morning, everyone. I am Dr. Gauri Chakraborty, General Surgery Trainee from Chattogram Medical College Hospital, Bangladesh. Would like to share with you a short presentation on social aspect of physical assault, which is an interim analysis of ongoing research. Short presentation on social aspect of physical assault, which is a place where the analysis of ongoing. So, why we have come up with this topic? As we know, injuries due to violence are widespread among the age 1 to 44 in the society, and it's a leading cause of death and disability. Physical violence often arises from particular demand or difference of social power. When we keenly looked back for the cause, we saw there are some socio-demographic variables that showed strong association to physical violence. These are the data from a different study that had been conducted in the same hospital a few years back, showing pattern of injury and cause of injury. Here we can see significant percentage of people got injured due to personal dispute. Why this violence and intolerance nowadays are increasing in number, these thoughts encouraged us to go for background analysis. That's why we have prompted to go with this study to get a clearer view of socio-demographic dispersion as well as gender vulnerability of physical assault in Bangladesh. Let's begin by looking at the synopsis of this study. This observational study took place in the Department of Casualty, Chattogram Medical College Hospital, among the patients of physical assault with all age group. For the interim analysis, we collected data from March 2019 to August 2019. We took 236 samples which were interviewed and examined clinically and radiologically, and by abdominal ultrasonography as required. The answers and examination findings were recorded in a pre-designed data collection form. Prior to that, informed written consent was taken. Data were analyzed to identify the social vulnerability of physical assault in terms of type of assault, vulnerable age group, etiology, relation to literacy, area predisposition, and type of assailants. Firstly, I would like to draw your attention on this cross table on age and gender distribution, which reveals males are vulnerable at all age group. Age range vary from 10 to 49, mostly below 30 years. Let's see how they are being affected. This pie chart illustrates several modes of injuries. Among them, sharp and blunt altogether are common mode of injury, that is more than 90%. On the contrary, bullet and pellet injuries are less common, that is less than 10%, which indicates firearms are still not so available to common people in our country like the Western world. This mode of injury leads me to my next slide, that is type of injury, which depicts penetrating injuries are predominant. An interesting fact is that a significant number of patients showed no external injury, which implies they might be involved in hand-to-hand struggle. When we elaborated the pattern of penetrating injuries further, we saw vascular and deep organ injuries are quite high, that is life-threatening. On the contrary, blunt trauma caused superficial injuries mostly. Next 3 slides will highlight on the area predisposition at city, district, and divisional level. Here in Chattogram metropolitan city, we can see Baijit Bostami is the most vulnerable area. In Chattogram district, Anwara Thana is the most vulnerable area, and in Chattogram division, large number of cases come from Cox's Bazar district. Why these areas are more vulnerable, that observation will be discussed on later. Let's consider another aspect, that is relation to literacy. By this bar diagram, vulnerability to assault shows inverse relation with literacy. Here we can see the most people involved in assault belong to illiterate and below 10 standard group. Now we will focus on etiology. Burglary and interpersonal dispute were the significant causes. One important observation is that the number of unidentified causes were also very high. Besides this, urban and rural distribution of assault is illustrated by this bar diagram, which implies urban people mainly got affected by burglary and interpersonal dispute, where rural people become victim of land dispute and sports violence mostly. This cross table on gender distribution of causes of assault shows males are more affected by interpersonal dispute and burglary, where family dispute involved both gender equally. Next slide will exhibit the number of cases assaulted by whom through a bar diagram. Here we can see maximum victims were affected by unknown person and quite a large number were affected by neighbors and friends. From this analysis, some important observations have come up. To put it simply, the people of most productive age group 10 to 49 with male predominance was found to be affected by physical assault mostly. That should be a burning issue in public health because injuries come up along with physical and emotional distress, financial burden, death, lifelong disabilities, and society is also robbed of the contribution that these people could have been made by their work. Victims are mostly affected by sharp and blunt mode of injury, causing penetrating type and incise-blocking wounds, which indicates that miscreants were increasingly carrying sharp weapons along with them, which is alarming. The industrial areas and relatively lower income group residential areas were most vulnerable, like the Baijit Thana and the Anwara Thana, because industrial workers and migrated people lived here. Socioeconomic instability, lack of social security, loose social bonding, lack of sense of responsibility, and low literacy rate probably made this area more vulnerable. Again, more precise research design is required to explain the causes of high rate of physical violence in district and divisional level, because this is not the only hospital to receive this sort of patients. Most minor injuries were handled by doctors locally at local areas. Inverse relation of physical violence to literacy rate may correlate the situation. From the consensus of Bangladesh 2015, we get to know that the literacy rate of Cox's Bazar and Anwara is less than 50%. Furthermore, burglary as a prominent cause of physical assault clearly indicates the inadequate maintenance of law and order situation. Another important observation is that unidentified causes of assault, in which victims were not interested to disclose due to shame, guilty feelings, or in fear of social harassment. This percentage is also very high in this study. So, this is very difficult for any law enforcing agency or social care organization to address those issues. As a result, the accused get away with impunity. So, it's very hard to prevent this type of assault. Increasing personal intolerance among the young population, family and interpersonal relationship are also required to be addressed. Males are more affected by all types of etiology, while assault and family dispute involve both gender equally. It presumes that in this socio-cultural environment and family structure, both male and female plays important role in the process of family dispute. So they earn equal vulnerability in this variable. Cautious dealing with the neighbor and unknown person seems to be beneficial in reduction of the incidence of physical assault. Despite of all the efforts, there are some limitations in the study, like this is a single center study, sample size is small, and this is an interim analysis, not a complete study. So I would like to wrap up my presentation by saying that physical assault is becoming an emerging threat to the inhabitants of the study areas. So law enforcing agencies should be more active here, and various social awareness programs should be addressed to improve the interpersonal relation and family environment. Further studies in other areas of the country should be performed in collaboration with public health community, local government, law enforcing agencies, social care organizations, healthcare providers to throw a light on the situation prevailing in rest of the country. These are some references. Thank you all for patience hearing.
Thank you very much, Dr. Chakraborty, for that presentation. I do apologize for the inconsistencies in the recording initially. Apparently there were some gremlins in the system that created a few problems, but I think that stopped after about the first minute. So thank you again. Can I please remind the audience that the Q&A box is open. If you have any questions for any of the presenters on any of their findings, can you please put those questions into the Q&A box? And we'll hopefully get time to ask them of the presenters. I would like to invite our discussant for this paper, Dr. Kate Martin from the Royal Melbourne Hospital in Melbourne, Australia, to discuss this paper, please. Dr. Martin.
Thank you, Dr. Demors, and congratulations, Dr. Chakraborty, on an excellent paper. This is a very, very important part of the work we do, so you should be commended for the efforts in dealing with what is a very difficult problem. I do have a couple of questions for you. This is a retrospective study. It's predominantly looking at the prevalence of violence and injuries in this group of patients. Do you think presumably there will be a number of, or a population of patients who have not presented to hospital for care? Do you have a sense of how well the study population that you have looked at represents the population of Bangladesh as a whole? And I was just wondering if you can make a comment on that, please.
Thank you, Dr. Martin. Please respond to the questions, Dr. Chakraborty.
Thank you, ma'am. Thank you for nice questions. Actually, the study area that we have chosen, that is the southeastern part of the country. That is the Chattogram division. This is the one of the largest area of our country, and it is one of the largest division geographically. This is the largest division of our country. So it covers almost the southeastern part of the country, and more than 3 crore people lived here. So I think if we can study this population, then we can presume an idea. We can take an idea that what may be the situation in other parts of the country.
Excellent. And to complement this this prevalence study, do you have any access to data on those patients who unfortunately die before getting to hospital? So are there any police records or police data that you can access to see if the population of patients who end up dying because of violence and never making it to hospital are different to the population who do make it to hospital?
Some people brought the victims, brought dead in hospital, but some are not. So it's very difficult to make a comment on that, on this study.
Okay then. And my final question then will be, what will you do with this information? What will be your next step? You spoke about some social awareness and improving the tolerance between neighbours and family members, but with a significantly illiterate population, have you had any thoughts on how you will use this data to help prevent further violence in the future?
Because we all know trauma prevention is becoming a major part of trauma management program, and social awareness program plays a major role in trauma prevention. So if we can make some collaboration with the social care organizations and the religious and political leaders, local government, law enforcing agencies, and take some measures to make a policy how to approach to those people who are illiterate and how to those who are less educated, then we can approach to them to improve their personal relationship, to improve the tolerance between them.
Thank you very much, and congratulations again on a really important study. Thanks.
Thank you very much, Dr. Chakraborty again, and thank you, Dr. Martin, for your questions. Mrs. Paltridge, are there any questions from the Q&A box?
No, Dr. Demores, there's no questions.
All right, we'll move on to the next paper. Thank you again. Our next presenter.
Thank you, sir.
Our next presenter is from Singapore, Dr. Yun Lee Lin. And the title of the presentation is Long-Term Outcomes Following Major Trauma, Review of a Prospective Database in a Singaporean Tertiary Hospital. Welcome, Dr. Lin.
Very good afternoon from Singapore. My name is Yun Le, and it is my honor to be able to address everyone today. I'll be presenting my work done with the Department of General Surgery in Singapore General Hospital entitled Long-Term Outcomes Following Major Trauma. Some background. The introduction of the ATOS program was a milestone in modern management of trauma patients and has been associated with a reduced mortality, with one study demonstrating up to 50% reduction in trauma mortality post-ATLS. However, the consequences of trauma are often more far-reaching, with sequelae ranging from functional, psychological, physical, and financial. One study found the one-year treatment cost of adult major trauma in the US to be $27 billion annually. At present, there's a paucity of data with regards to long-term effects of trauma, particularly in the Asian population. A more comprehensive understanding is needed to guide resource allocation to minimize the long-term sequelae. The aim of our study was hence to determine the long-term outcomes in patients following major trauma. We performed a review of the National Trauma Registry data from 2016 to 2018 on patients who admitted to the Singapore General Hospital who suffered major trauma, defined as having an injury severity score of more than or equal to 16. This was a national database that prospectively collected information on all trauma patients. Aside from the baseline demographics and treatment information collected, there were three main outcomes we looked at. Number one, we looked at the patient's disposition at 6 months. This included the residence, work status, and ambulation status 6 months post-trauma. Secondly, we looked at the self-rated state of health. This was done by a self-rated visual assessment scale performed at 6 months post-trauma, whereby patients rated the state of health at that point of time and prior to trauma, with 0 being of poorest health and 100 being the healthiest. Thirdly, we looked at the functional outcome scores at 6 months. This includes the EuroQOL 5-dimension or EQD5, a multi-parametric tool assessing one's coping with mobility, self-care, daily activities, pain or discomfort, and anxiety or depression, as well as the Glasgow Outcome Score Extended or the GOSE, which assesses the state of a patient's neurorecovery post-trauma. The registry data were collected by staff of the trauma team and were performed via phone interviews with patients and their carers. So these are our results. A total of 637 patients were treated for major trauma with our injury severity score of greater or equal to 16 between 2016 and 2018. The median age was 64, with 68% being male, 75% being Chinese, 42% of PSA1 status, and a median Charleston comorbidity index of 3. Fall from height accounted for over 50% of presentations, and motor vehicle accidents were over 25%. A large component of injury were made up of head injuries with the median AIS heat score of 4. The median ISS was 24. 24% of patients needed transfusion, 3% needed massive transfusion protocol to be activated, 43% needed surgery, 29% needed ICU. Median length of stay was 10 days. 13% eventually went on to need inpatient rehabilitation, and 13% developed inpatient complications such as pneumonia or urinary tract infection. The inpatient mortality rate was 4%. At 6 months, 20% of patients had passed away. Of the remaining patients, 40% were lost to follow-up for reasons that will be explained later. 60% responded to phone follow-up, amounting to 292 patients. Among the respondents, 88% were back to their own homes, 10% ended up in nursing homes, and 2% were still undergoing rehabilitation. 17% returned to work, 52% remained unemployed, and 31% were premorbidly not working. 55% were able to ambulate independently, with 38% needing assistance and 7% being unable to ambulate. There was a significant reduction in self-assessed state of health as measured by the visual assessment scale from 73 at baseline prior to the trauma to 64 6 months post-trauma. This slide shows the EQD5 assessed at 6 months. The 5 bars represent the patient's coping with mobility, self-care, return to usual activities, pain or discomfort, and anxiety or depression. Patients either have no problems, some problems, or were unable to cope with each aspect, as depicted by the brown, green, and orange boxes respectively. 36% had problems with mobility, 25% had problems with self-care, 25% had problems with returning to their usual activities, and 25% had issues with pain or discomfort. 6% reported depression or anxiety. This slide shows the GOSE finding at 6 months. As we can see from the chart, 32% remained severely disabled as demonstrated in the orange segment. 15% were moderately disabled as demonstrated in the green segment. 53% reported good recovery as demonstrated in the brown segment. Our study demonstrated 3 key findings. Firstly, at 6 months, 1 in 10 patients were not living at home, 1 in 2 remained unemployed, 1 in 2 were unable to ambulate independently. Secondly, patients felt that they were at a worse state of health 6 months after the trauma than before. Thirdly, 1 in 4 or more patients had issues with self-care, going back to their usual activities, having pain or discomfort. While a lesser number reported anxiety or depression, there is reason to suspect this may be suboptimally assessed and diagnosed in this population, especially in an Asian culture where there's still some stigma surrounding mental health disease. A mere 1 in 2 reported good functional recovery. This clearly highlights that our patient stories do not end after discharge, and there's a need for multidisciplinary management, including input from rehab physicians, pain specialists, and psychologists, even after our patients have left hospital. We acknowledge the limitations in conducting surveys in the trauma population who are often still having ongoing issues and may be suffering at 6 months. In particular, there was an inability to achieve a higher follow-up rate as the number of patients were still institutionalized or were just uncontactable. Future recommendations include prospectively following through with all trauma patients in a clinical study setting to better understand their functional outcomes and needs post-trauma. We would also like to conduct a dedicated study to explore the causes of mortality post-discharge. Multidisciplinary clinics involving rehab physicians, pain specialists, physiotherapists, occupational therapists, and social workers could be created to collaboratively assess and address the ongoing functional needs of patients. These should run for at least 6 months or longer. In conclusion, Mr. Chairman, I would like to present the conclusions of our study. We found that patients who experience major trauma experience significant sequelae 6 months post-trauma. and these include a failure to ambulate, work, self-care, and carry out their usual activities. These findings are identified for the first time in a Singapore context. The multi-domain nature of trauma recovery necessitates the involvement of a multidisciplinary approach in rehabilitation and allocation of resources to maximize functional recovery beyond the initial hospital stay. Thank you everyone for your attention, and I'd like to thank my mentor in the Department of General Surgery in Singapore General Hospital for their support. Also a special
I think I missed the last little bit of that recording there when you were thanking your mentors, but thank you very much, Dr. Lin. I think I enjoyed that paper, and it's an area that many people have difficulty with in terms of long-term follow-up. So congratulations on trying to provide some of that information. I'd like to invite our discussant for this paper, Dr. Sushma Sagar, who is a professor and division in charge, Division of Trauma Surgery and Critical Care, JPN Apex Trauma Center, All India Institute of Medical Science in New Delhi. Welcome, Dr. Sagar.
Thank you, Scott. Thank you for the kind words. Dr. Jim Lin, you have presented a wonderful paper, and you have touched a topic which most of the time trauma centers and the faculty and the residents over there are busy treating patients and forget this part of the registry and the analysis of this registry. I just want to know from you that does your hospital cater to all kinds of emergencies, or is it mainly the head injury patients? This is my first question.
Thank you, Dr. Sushma, for your comments. So yes, our center is a tertiary hospital, and it's a trauma center, so it caters to all forms of trauma, regardless of etiology.
Okay. Because what I have seen in your paper that most of the patients have come from fall from height, and majorly your patients includes head injury patients. So the problem with the head injury patients is more in their long-term outcomes. The rehabilitation part is more so. And the operative rate, which I have seen in your paper, is only 43%, because if you have more of patients with the torso trauma, then many of them, they undergo surgery and they recover fast, and you can have a better outcome in those patients as compared to the patients suffering from head injury. So that might have given a poorer outcome in relation to VAS and EuroQL in your patients.
Yeah, I completely agree with you. As you rightly mentioned, a large proportion of our mechanism of injury come from fall from heights and come from motor vehicle accidents. I think this is reflective of the nature of trauma in Singapore, which is a highly concentrated city-state where there's a large proportion of land that's made up of built-up areas, notably with numerous construction projects, which explain a high proportion of fall from height. Motor vehicle accidents also come in second with about 25%. And that also reflects the built-up nature of Singapore with extensive infrastructure network, but also with relatively orderly traffic with compliance to speed limit, and also a lack of long stretch of roads, which may result in high-speed injuries. There is also a component, there are also patients that were admitted to us with abdominal injuries, extremity injuries. However, predominantly the patients were, as you rightly mentioned, of head injuries. And of course, there are a number of patients with multi-system injuries as well. So having injuries of multiple regions, but having a AIS score of the head of the, having a higher score of the AIS head.
Yeah, my last question to you is that what do you mean by resource allocation? How are you wiser after this study about the resource allocation for your patients?
Yeah, so thank you for the question. So clearly, I think our study shows that 6 months after the trauma, a lot of our patients are still not doing well. And even during the phone interview with the patients, we find that a lot of times they voice problems such as financial issues, difficulty navigating the hospital system, difficulty with caregiving, and psychological need for support. So I think that knowing this information, it shows us that we need to actively follow up these patients for a longer period of time. And as mentioned in the discussion, I think that it will be good to have a multidisciplinary clinic, which is of a combined setting where the carers and the attender and the patients can attend the clinic, where on the health provider side, we have surgeons, rehab physicians, allied health therapists, social workers, psychologists, and pain specialists who can perhaps come together and work out the needs of these patients so that we can tailor the treatment plans to their need. And in this way, we make sure the care we give is rounded, whether it's their financial needs, whether it's their caregiving needs, whether it's their psychological needs or pain, or whether it's functional needs like having more physiotherapy and how do we get that, and whether they can pay for these services. I think that it shows that we need to have a very concrete plan and a very cohesive plan that's not just of any discipline, but of our entire system that we can provide to our patients. Yeah.
Thank you so much. Thank you very much, Scott.
All right. Thank you very much, Dr. Segal, for your questions, and thank you, Dr. Lin, for answering them. Is there any questions, Mrs. Paltridge, from the Q&A?
Yes, we have a question that is asking, because of the skew of patients towards geriatric patients in your study, is this unique to the Singapore experience and will it affect the outcome?
Thank you for your question. So actually looking at the age range, the median age is 64, the lowest age is 16, and the highest age range is 100. So, I mean, I think that we have a large variety of patients with different presentation, from the child crossing the road that got hit by a bus, or from the construction worker who's constructing a building and fell from a height. So I think that given that there's a large mixture of patients being involved, I think that it will not, and it doesn't necessarily skew the results to one direction, but definitely there is also the group of patients that of the geriatric population, and I think even more so, these patients need to be given attention in terms of the caregiver situation that they have, the financial situation, and even in terms of their physical function, ambulation, that they are cared for even after discharge. Yeah.
Okay, thank you again very much for responding to those questions, and we'll move on to our next presenter now. Our third paper is going to be presented by Dr. Jason Hong from Australia. And the paper is titled Factors Influencing the Implementation of the Canadian C-Spine Rule in Blunt Trauma. Welcome, Dr. Hong.
I'd firstly like to thank the organising committee for allowing the opportunity to present. My name is Dr. Jason Hong, one of the general surgery registrars from Box Hill Hospital as part of Eastern Health in Melbourne, Australia. Our project was on the factors influencing the implementation of the Canadian C-Spine rule in blunt trauma. This was a collaborative project between the Departments of Surgery, Emergency Medicine and Medical Imaging, and I'd like to thank a range of people who helped to assist in this project. Clinically significant cervical spine injuries occur in approximately 1 to 3% of stable blunt trauma patients, and missing these injuries can have devastating consequences for patients. Various tools have been developed to help guide imaging in these patients, such as the Nexus and Canadian C-Spine rule. We noted at our institution that scanning rates have been increasing, so a pilot study was performed and previously presented involving over 900 trauma patients, where we implemented an evidence-based tool, the Canadian C-Spine rule, and we found that we reduced the number of cervical spine scans being performed by over 30% without compromising patient safety, with a sensitivity of over 97% and an injury detection rate of 5%. So our aim was to review the use of this newly implemented tool and to address areas of improvement. We wanted to know how many unnecessary scans were actually being performed, whether we were using the tool correctly, whether we were actually applying the tool whenever we saw a patient with a suspected neck injury, the impact on patients for incorrect use, whether there was a difference in time of presentation and our documentation rates. So this was a retrospective study of over 900 trauma presentations to Box Hill Hospital over a 12-month period. We audited the form, which was the Canadian C-Spine rule tool, which was filled out at time of patient assessment And then we reviewed the medical records of all patients to determine the appropriate use of the tool. The flow diagram on the right outlines our study population. We started with over 1,000 patients and 103 were excluded as non-trauma patients, leaving over 900 trauma patients. About half of these required scanning and half of them didn't. And of the patients that didn't, some still went on to have scans done. This is the Canadian C-spine rule flow diagram on the right. And I won't go into great detail for the interest of time, but suffice to say, there are 3 high-risk factors, 5 low-risk factors, and a clinical assessment which guides imaging. There is also inclusion and exclusion criteria, which are included in the top of this flow diagram. In terms of the results, we found 44 out of 423 patients, or approximately 10.5%, unnecessarily received a CT C-spine. And these patients subsequently did not have a cervical spine injury identified. We found that 1 or more of the low-risk criteria had not been followed. As you can see in the pie chart, over half of these patients actually had an absence of C-spine pain, and a large percentage were ambulatory at any time. We audited adherence based on time of presentation, and overnight it was lower at 80% compared to during the day at over 90%, and this was statistically significant. We wanted the rule to be used 100% of the time, but as you can see in this table, clinicians are still not using the rule, and even if they are using the rule, there are still unnecessary scans being performed. And we found more unnecessary scans were being performed overnight compared to during the day. We audited time in collar before clearance, and as you can see in the bar graph on the left, if a scan was not required based on the rule, as expected, these patients were in collars for only 1.1 hours. If a scan was required based on the rule, these patients were in collars for 5.7 hours. However, for the patients who received an unnecessary scan, these patients were in a collar unnecessarily for an average of 4.8 hours. And you can see on the pie chart on the right that a quarter of these patients who received an unnecessary scan were actually in collars for 6 to 8+ hours. We audited time in collar until assessment, whether that be applied by the paramedics or the ambulance staff versus the emergency staff. As you can see from the table, time increased overnight compared to during the day, and coupled with the previous slide showing an average of 4.8 hours unnecessarily in a collar for those patients, this leads to increased complications and increased patient discomfort. We also audited our documentation rates, and this is an area that we could improve upon. So there seems to be a lower uptake and increased rate of incorrect application of the rule overnight compared to during the day. There could be a number of reasons for this. There are usually fewer staff on overnight compared to during the day, and this can lead to increased pressures to see patients in a timely manner. There could be fewer senior clinicians overnight to ask for advice. Focus groups are required to further explore the reasons behind this. Education will be key, in particular to night staff, to increase awareness and to decrease the rate of unnecessary scanning. Integration into our already pre-existing electronic medical records is an exciting prospect, and work is underway, as well as having pop-ups and reminders to prompt clinicians when seeing suspected neck injury patients to help guide imaging. Some of the limitations of this study include its retrospective nature, the fact that it was a single centre study, and it was assumed that the Canadian C-spine rule tool wasn't used if the audit form wasn't completed. So in conclusion, the Canadian C-spine rule tool has rationalised scans and reduced overall scans being performed without compromising patient safety. However, there are still unnecessary scans being performed at about 10.5%. Some of the areas to improve include closer scrutiny of the Canadian C-spine rule, reducing nighttime unnecessary scanning, and better documentation. And we can do this through education and integration into our pre-existing system.
Thank you very much, Dr. Hong, for that presentation. I would like to invite our discussant for this paper, Professor Andre Das, Professor of Surgery and Trauma from Malaysia. Professor Das, are you there?
Yes.
There you are.
Thank you, Jason, for that excellent paper in looking to the dimension of quality in trauma care. I have just a few questions, and I'll start with the simple question first. Is there an accepted standard of care for the management of cervical spine, either in Victoria or in Australia?
There is, at our institution, there wasn't a accepted standard of care in assessing neck injury patients, especially the stable blunt trauma patients. So that's why this tool, this validated tool, the Canadian C-spine rule, was introduced. And now that has become the standard of care at our institution. I can't really speak for other institutions. Obviously, there is the validated Canadian C-spine rule tool, as well as the Nexus criteria, which can be used as well, which has been extensively studied. So these two tools I know are used in clinical practice, but I'm not sure if they're the standard of care in other institutions.
So maybe that would answer why there is a very little compliance, since it's not an accepted standard of care in either Victoria or Australia. And have you thought of any strategy to address this point if that is the case?
I can't speak for other hospitals and other systems, but I can speak for, I guess, our institution. We know that there wasn't a standardized method of assessing neck injury patients. And then we noticed our scanning rates were increasing, and it was unsustainable to have the scanning rates increase with increasing costs. So we needed a way to try to minimize the scan rates, but still have a highly sensitive tool, because obviously we didn't want to miss any clinically significant neck injuries. So so therefore this tool was introduced, and that was one of the impetuses to introduce this tool was because of that, and it was it's been validated as the original tool, 100% sensitive.
So maybe you could engage the College of Surgeons to maybe push this forward from your study. Is that an option?
Definitely, yeah. So I mean, we've shown it to be a highly effective tool, and well implemented and very safe for patients. So definitely, yeah, worthwhile. We could look into that and have it implemented at other centres, smaller centres, as well as I'm sure the major trauma centres are using this as well.
Just a short question. Was there any required, in the group that required scanning, were there any patients that were not scanned? On the other hand, now we are looking at patients who did not require scanning but were scanned instead. But I think more importantly, were there any patients who required scanning but were not scanned?
So patients who required scanning and were not scanned. We looked thoroughly through those 900 patients, and so the patients that had the rule applied and they required scanning, they went on to have scans done. So yeah, so it was.
So there was none left out. Okay, thank you, Dr. Jason, and back to you, Scott.
Thank you. Professor
Thank you very much, Andre. Mrs. Paltridge, are there any questions in the Q&A box or the chat box for Dr.
No,
Hong?
there are no questions for Dr. Hong.
Okay, we'll move on to the next paper then. Thank you. Thank you again, Dr. Hong, for your presentation. Our next presenter is Dr. Zen Kwanggu from Malaysia. And the title of the paper is Reduction of the Duration of Mechanical Ventilation Using the Trache Score to Guide Early Tracheostomy in Neurological Cases. Are you there, Dr. Gu?
Hello, my name is Gu and I'm from the University of Malaya, Malaysia. Today, I'll be presenting on the research that we have done in University Malaya with the topic of reduction of the duration of mechanical ventilation using the TRAC score to guide early tracheostomy in a neurosurgical setting. As an introduction, tracheostomy is a surgical procedure usually done on patients who are mechanically ventilated beyond 7 days. Early observation shows that there are some benefits of early tracheostomy compared to late tracheostomy in this group of patients. However, the actual reason of this observation remains unknown. These are some recent papers that are published looking at early versus late tracheostomy. As you can see on this table, the patients are of various background, either from the intensive care unit or with traumatic brain injury. And the most striking features of all these papers are the non-standardized definition of early versus late tracheostomy. Early tracheostomy ranges as early as 4 days up to 10 days, and the results were heterogeneous, and there's no consensus on whether an early tracheostomy is more beneficial than a late tracheostomy. Of note, all these papers have different criteria deciding patients to undergo early tracheostomy, and most of them depends on clinical features of the patients. Tracheostomy score or TRAC score is a score that utilizes patients' clinical parameters and radiological parameters to predict their likelihood of prolonged ventilation. This is the formula for TRAC score. It has a sensitivity of 94% and positive predictive value up to 83%. To illustrate TRAC score better, this case scenario further explain it. So let's say we have a young patient who had a motor vehicle accident, came in with a GCS of E2, V2, and M4, has a subdural hemorrhage with a midline shift of 11 millimeter. The TRAC score would be 3 is the constant, and the midline shift of 11 mm give 3 points in the second component, and we will minus off the total Glasgow Coma scale divided by 2. And this patient has a TRAC score of 2. If you look at the graph on your right-hand side, a TRAC score of 2 can predict the likelihood of prolonged mechanical ventilation up to 90%. So our clinical question for this study is, would performing an early tracheostomy have a shorter days of total mechanical ventilation post-tracheostomy in a neurosurgical setting? This is a single-center randomized controlled trial. A sample size of 17 in each arm were calculated using a moderate effect size. And this study is approved by the University Malaya Medical Research Ethics Committee. This is the approval ID. The study was conducted from July 2019 to July 2021. The patients who presented at 48 hours of presentation, the TRAC score of the patients were calculated. Patients who have TRAC score of 2 or more were included once we obtained the consent from next of kin. The patients who were unlikely to survive based on their presentation had cardiac arrest on arrival, had coagulopathy enough to contraindicate a tracheostomy, had upper airway obstruction required immediate tracheostomy, were excluded from the study. Enough time were given to the next of kin to think and give consent, and the pros and cons of tracheostomy were explained to the patient's next of kin. There were 3 next of kins who refused tracheostomy, And all patients undergo a stratified randomization into a 1-to-1 ratio to either early group or the standard tracheostomy group. Early group would have their tracheostomy performed before day 7 of mechanical ventilation, and the standard group will have their tracheostomy performed at day 7 or after day 7 of mechanical ventilation. We have excluded 2 patients because they were extubated prior to the tracheostomy. The statistical analysis were performed and the appropriate tests were used, namely chi-square tests and independent t-tests. A p-value of less than 0.05 were considered as statistically significant. These were our results. Looking at the early and standard group of patients, there were no statistical difference in terms of their age, their gender, ASA score, and body mass index. When we look at the stratified randomization, they were equally randomized into both groups, be it their intracranial pathology is traumatic brain injury or intracranial hemorrhage. Their septum pellucidum shift and the largest blood clot diameter were not statistically different as well in both groups. The mean tract score was similar in both groups, and the GCS on the days of tracheostomy were same in both groups. When looking at the outcome, there was a statistically significant difference in the days of ventilation post-tracheostomy. In the early group, the patients were ventilated on an average of 11.9 days, where the standard group were ventilated on an average of 18.9 days. Of note, it's also important to notice that these patients were actually ventilated for more than 14 days in total. However, when we look at the total days of ICU stay and total days of hospital stay, there were no statistical significance difference in both groups. Our studies has a few limitations. As this is a single center study, it's difficult for us to generalize the findings to other centers. There were no long-term results from our studies, and we found it difficult to obtain the consent from the next of kin at the first instance. However, with adequate time and proper explanation to the next of kin, usually they will agree to performing a tracheostomy on patients who likely require prolonged ventilation. The strength of the study, we use an objective tool to predict prolonged ventilation, and we were able to reduce the ICU utilization, which may be helpful during this COVID-19 pandemic. As a conclusion, early tracheostomy is associated with a shorter duration of mechanical ventilation in a neurosurgical intensive care unit setting. We were able to reduce the total days of mechanical ventilations up to 7 days, with a 37% reduction in the patients who underwent early tracheostomy. With that, thank you.
Thank you very much, Dr. Gu, for that presentation. I think we have Professor Macalino here. Professor Joel Macalino is a professor of surgery, division head, surgical critical care, and head of trauma and critical care, Philippines General Hospital. Welcome, Professor Macalino.
Thank you very much, Scott. So, good afternoon, Dr. Gu. I have a few questions. Anyway, I really enjoyed reading your paper because I was interested. Because right now, we share our ICU with the neurosurgical ICU. So you can just see how much potential our patients would be or would benefit from your study. But then doing a quick search in the literature, I came up with this more traditional time of 14 to 21 days across the board before tracheostomy is being done. And that is what we follow. And that is across the board, not only for neurologic patients. Meaning the supposedly early tracheostomy or even the standard tracheostomy in your study is also considered practically an early tracheostomy as regards to our patient. Can you comment on that?
Thank you, Prof, for the question. That's a very good question, and it's very relevant to what we have done. So the novelty of this study is by using an objective tool to predict the likelihood of prolonged ventilation. So this prolonged ventilation, though has been traditionally been commented as 14 to 21 days, but by using these tools, we can quite accurately predict the likelihood of prolonged ventilation in this group of patients. We do face a problem from, the questions from our ethics committee when we want to perform a tracheostomy as early as before 7 days. And even in the standard group, we put it at day 7 and above. Now, in the past studies, they always comment as early versus late tracheostomy. We dropped the word late and replaced it with standard because we thought that mechanical ventilation of 7 days and above should be considered as a prolonged mechanical ventilation as well. So that's how we came to doing the study and setting the days at day 7.
Regarding your study, there was a clear difference of 1 week or 7 days between the early and the standard group. So did that translate to shorter ICU stay?
If you look at the days of ICU stay, it's actually shorter by, I think, 4.5 or 5 days. But it was not statistically significant because based on the sample size calculation that we use, the duration of ICU stays were not the objective of our study. So the effect size, I think if we want to measure the difference in the ICU stay, we need a bigger sample size.
You started your study, one last question, sir. You started your study in July 2019. Do you have by now follow-up, long-term follow-up data as regards to these earlier patients in terms of long-term outcome for the post-tracheostomy patients?
We have them, but we have not analyzed them, Prof.
Okay. And one last, if I may. Do you do your tracheostomy with the PEG? I mean, concomitant with the PEG already?
No, just the tracheostomy.
Okay, thank you very much. Thank you very much, Scott.
Thank you very much, Joel. Mrs. Paltridge, are there any questions from the Q&A box? We have a little bit of time if there are any questions.
Yes, there are. So the first question is, does the TRAC score take into consideration the pulmonary status of the patient, for example, presence of pulmonary contusion or aspiration, pneumonia, etc.?
That's an excellent question. We are working on that. So to answer the question, the answer is no. The TRAC score does not take into consideration of the pulmonary status, but we do think that this is an important factor in determining early tracheostomy or likelihood of prolonged ventilation. So what we are doing currently is with the patients that we have under our care, we also we hope that we can add this pulmonary status into our own center's protocol in deciding patient who likely requires prolonged mechanical ventilation.
We have time for one more question if it's a quick one.
Was consent taken for the study to be conducted?
Yes, the consent was taken from the next of kin because the patient are unconscious. They are usually ventilated. So the consent is from the next of kin, both for the study and for the procedure.
Thank you very much, Dr. Gu, and thank you, Mrs. Paltridge. Please do keep an eye for presenters if there are any other questions that are in the chat box or Q&A that we haven't been able to answer live on the screen. Please do feel free to answer them in the chat box, presenters. Our next presentation is by Dr. Lieutenant Colonel Takeo Ti from India, and the paper is titled "To Study the Role of Prophylactic Antibiotics in Patients with Chest Trauma at a Level 1 Trauma Center, a Pilot Randomized Controlled Trial."
Good afternoon, everyone. I'm Dr. Takeo Ti, Senior Resident, Division of Trauma Surgery and Critical Care, JPN ATC, AIMS, New Delhi. I'll present my research paper titled Role of prophylactic antibiotics in patients with chest trauma at a level 1 trauma center, a randomized controlled trial. Chest trauma accounts for a major chunk of all trauma admissions and deaths worldwide. Blunt trauma chest constitutes most of the chest trauma. The mortality rate from BTC ranges from 9.5% to 48%, depending on the severity of injuries sustained. BTC may present with spectrums of injuries such as hemothorax, pneumothorax, or hemopneumothorax associated with or without rib fractures. And in majority of cases, intercostal tube drainage or tube thoracostomy is the mainstay of treatment. Only in less than 10% of these injuries require thoracotomy. ICD exposes the patient to the risk of infectious complications, namely pneumonia, emphysema, and peritubral surgical site infections. The rationale behind the use of prophylactic antibiotics is to reduce the risk of complications and its associated morbidities. Thus, it will decrease the duration of ICD and length of hospital stay. And this, in turn, will lead to low cost of treatment. The lack of consensus on role of prophylactic antibiotic in BTC patient requiring ICD, the emergence of antimicrobial resistance bacteria globally, and the antibiotic cost burden to the patient and to the family, especially in developing countries like ours, were the main concerns which prompted us to do this study. So we hypothesized that prophylactic antibiotic is not required in patients with BTC managed with ICD. The main objective of our study was to compare the incidence of infectious complications in patients with BTC managed with ICD and antibiotic and those managed without antibiotic. We conducted a double-blinded pilot prospective randomized controlled trial at JP and ATC. All acutely injured patients presented to the ED between October 2019 and August 2021 were included in our study. The sample size was calculated using the data available from the previous studies pertaining to BTC requiring ICD managed with or without antibiotics. And we found the calculated sample size to be very large, at least 1,200 required in each arm, which was not feasible in the limited period of 2 years. Hence, we proposed to randomize 60 patients in each arm as a pilot study. We had very strict inclusion and exclusion criteria. Inclusion criteria were patients with age 15 years and above with BTC requiring ICD. Exclusion criteria were those with penetrating chest injuries, associated injuries requiring antibiotic administration, those requiring ventilator support on arrival, non-pulmonary disease or immunocompromised status, BTC patient requiring immediate thoracotomy, those already on antibiotic for some other illness or injuries, and finally, those who did not give consent. So after obtaining the consent, randomization was done using computer-generated list of random numbers, and the allocation consignment was achieved by using sealed opaque envelopes. The patients were randomized into two groups, Group A and Group B. Group A were BTC patients with ICD managed without a prophylactic antibiotic. Group B were BTC patients with ICD managed with prophylactic antibiotic till ICD was in situ. The antibiotic which we used was amoxicillin, that is amoxicillin plus chloronic acid combination, given as per the dose was as per the weight of the patient. It was administered either IV or orally 8 hourly. The rest of the treatments were similar in both the groups. Coming to the results, The total trauma admissions during the study period was 2,205 patients, out of which 1,048 patients had sustained thoracic trauma, 905 patients had BTC, out of which 350 patients required ICD. 230 patients out of 350 patients were excluded from the study for various reasons. They were those patients with associated injuries requiring antibiotic, those who were COVID-19 positives, and those on antibiotic for pre-existing illness. So finally, 120 patients who were eligible for inclusion were randomized into two groups, taking 60 patients in each arm. We found age and gender comparable in both the groups. The most common mechanism of injury in our study was RTI, followed by fall. The mechanism of injury, the mean ISS, mean NISS, and the mean TTSS, that is thoracic trauma severity score, were comparable in both the groups. Coming to chest complications, the overall complications were seen in 12 patients, 7 in no antibiotic group, and 5 in antibiotic group. The overall complication rate was comparable in both the groups. There was only one infectious complication, death to in antibiotic group, whereas none in no antibiotic group. The infectious complication rate was comparable in both the groups. The non-infectious complications were seen in 11 patients, 7 in no antibiotic group, 4 in antibiotic group. Similarly, non-infectious complication rate was comparable in both the groups. The duration of ICD and length of hospital stay were also comparable in both the groups. There was one mortality in our series. He was a case of BTC with T2 spine fracture without any neurological deficit. He was being managed non-operatively. On day 5 of admission, he developed sudden respiratory distress. He was immediately shifted to ICU and put on mechanical ventilator. MRI was done, which revealed cervical cord edema, leading to diaphragmatic palsy. He later on succumbed to severe respiratory complications. However, the final outcome in both the group was comparable. In conclusion, we found low incidence of ICD-related infectious complications in BTC patients. There was no significant difference in infectious complication rates between the antibiotic and no-antibiotic group. Definitive role of prophylactic antibiotic in reducing the infectious complications in BTC requiring ICD could not be established, and the prophylactic antibiotic therapy did not affect the duration of ICD, length of hospital stay, and final outcome of the patient. Hence, our recommendation was that overall ICD-related infectious complications in patients with BTC are rare. Use of prophylactic antibiotic is not required in BTC patients with ICD. However, we recommend a multicenter RCT with large sample size may be conducted to validate it further. We acknowledge our limitations in this study. One, it was a pilot study with a small sample size. And secondly, the study was undertaken within a single specialized trauma center. Thank you very much.
Thank you very much, Dr. Chiai, for that presentation. I'd like to welcome our discussant for this paper, Dr. Macalino again. Joel, please go ahead.
Hi, good afternoon, Colonel Takio. I have a few
Good afternoon, sir. Good afternoon, sir.
Good afternoon. So the use of prophylactic antibiotics across the board, again, for penetrating and blunt trauma is well studied. In fact, that's become a standard and advocated in the guidelines of Eastern Association for the Surgery of Trauma, the author of which is Dr. Luchete. And that prophylactic, their definition was that prophylactic would be within the 24 hours, either one dose or doses within the 24 hours. And beyond that, it's already therapeutic. So I think what you are comparing is prophylactic versus therapeutic. Now, what was advocated was the early generation cephalosporin. My first question is, why is it that any reason for the use of clavulanic, amoxiclavulanic acid in your study?
Yeah, good morning, sir. Actually, in our institution, we have an antibiotic policy. Augmentin, basically, it's a combination of amoxicillin plus clavulanic acid. And because it covers, most of the time, what we see is that gram-positive cocci is the most common organism which causes the acid-related infection. So Augmentin, it covers very good, it has a good coverage of gram-positive cocci. So that is the reason why we give Augmentin here in our institution. Secondly, sir, what you said is the Eastern Association for Surgery of Trauma Practice Management Guidelines. That was the first you are quoting, which you are quoting is the one which was published in 2000. They later on published again in 2012 in the Journal of Trauma Acute Care. And there they did a systemic literature review. It was done by Moran et al. And there they said that it's still a controversial subject and there's insufficient published evidence to support any recommendation either or against this practice. So there's still controversy.
Okay. In your results, I think the expectation was that supposedly therapeutic group would fare, or those in the therapeutic arm would fare better than the prophylactic arm. But then you had one infectious complication in the therapeutic arm. So can this be explained only by the lack of sample size, or do you have any explanation for this?
Yeah, sir. One I would say is lack of sample size because it was a pilot study and the sample size was 120. So it's difficult to give conclusion right now. But whatever was the finding, we felt that it's not significant. It's not significant.
And then my last question, I think you'll be having a hard time convincing the ethics committee to again approve that of a multi-center study, considering that it was not clear in your study the benefits of prophylactic versus therapeutic antibiotics. Can you comment on that?
Yes, sir. It's really hard to convince them. And this is such a subject, there's a lot of controversy right now. I mean, there are studies, if you go and see literature, there are a lot of studies which favors prophylactic antibiotics, like a systemic review done by systemic review and meta-analysis done by Ayub et al. And Sonabria. They say that there's a benefit of giving prophylactic antibiotics, whereas there are other studies like Koch et al., which was published in the Journal of Trauma Surgery and Acute Care, where they have done a multi-center study, and it was under the sponsorship of the American Association of Surgery of Trauma, and there they found that there's no role of antibiotic. So it's a controversial subject. And second, the reason why we did this study was basically because our institution, in general, we are following, giving antibiotics. We do give antibiotics. Now with this study, at least we know that it will change our practice. We'll stop giving antibiotics. So that is the reason why we did this study. And as you said, yes, it's very difficult to do multi-center study, and it will be a tough time, convincing the ethics committee. True, sir.
Lastly, one comment, Colonel Takio. I also serve in the Philippine military, Philippine Armed Forces, so we are kind of related. Thank you very much.
Comrade in arms, sir.
Scott, thank you.
Thank you very much, Joel. We've expired on time, so would you please, Dr. Takio, have a look in the Q&A box and chat box, just in case there are any further questions there for you to answer.
Sure.
Thank you again.
Thank you very much.
We'll move on to our next presenter. Our next presenter is Dr. Neralyn Panghasapon from Thailand. I'm not sure, just double check. Do we have Dr. Neralyn online?
Yes, I'm already here.
Yes, very good. Okay, we will start your presentation, which is entitled Accuracy and External Validation of the Modified Rapid Emergency Medicine Score in Road Traffic Injuries in a Bangkok Level 1 Trauma Center. Dr. Neralyn.
Good afternoon, everyone. My name is Neralyn Panghasapon from Navamintara University, Bangkok, Thailand. Today, I'm going to present my research, the external validation of modified rapid emergency medicine score for in-hospital mortality prediction among trauma patients. Nowadays, trauma is a primary cause of death all around the world, which incident is about 5 million deaths per year. According to this figure, road traffic is a leading cause of all that injury. In Thailand, the incidence of road traffic injury were increasing every single year, up to 8,000 people per year. So, many trauma score was developed to predict the mortality rate in trauma patients. They classify the trauma score into physiological and anatomical scoring system. The accurate physiological scores such as Revised Trauma Score and MGAP, but is not validated in Thailand. And the accredited and validated score in Thailand is Injury Severity Score. That is an anatomical score which calculated from the definitive diagnosis of injury organ system. So even the excellent prediction of the injury severity score, but is not applicable at emergency department. Now, there is a study developed, the MRE in the American trauma patient, which had an excellent discrimination performance, better than Revised Trauma Score and MGAP. So, our primary objective of this research is to validate that MRE for in-hospital mortality prediction among road traffic injury patients. And the secondary objective is to estimate in-hospital mortality in each range of MRE and to compare mortality prediction with the RTS and MGAP. This research is a retrospective cohort study which collects the data road traffic injury patients in Vajira Hospital for total 4 years, from 2015 to 2018. The total people is 1,033 patients. Follow the inclusion criteria, the patient have to age more than 15 years old and affect the road traffic injury. And they got a treatment at the emergency department and admit in the hospital. And we exclude the patient that refer from another trauma, medical care, or pregnancy. This table showing a scoring scheme of age, systolic blood pressure, heart rate, respiratory rate, oxygen saturation, and gas-coma scale as a predictive factors. Some predictors also used in both RTS and MGAP. Statistical analysis in this study. We describe the data using mean with standard deviation or median with interquartile range for continuous data, and describe the percentage in the categorical data. We compare data between death and survive group using a t-test and man-Whitney U-test for continuous data and chi-square test for categorical data. For model evaluation, we use the logistic regression by fitting the death outcome with the calculated score from the MREMS scheme. Then ROC curve was plotted and area the ROC curve was calculated. AUC of the MREMS also compared with the AUC of RTS and MGAP. We also access the calibration properties of MREMS in our dataset by using Hosmer-Lemnitschov goodness of fit test, and the observed probability of death was compared with the expected probability by OE plot and ratio. Our results show that 33 from 1,033 patients died from road traffic injury. And among the characteristics between two groups, only mechanism of injury, severity of head injury, and the oxygen saturation level was significant difference between groups. When MREMS was stratified according to MREMS original study, the higher mortality rate was observed at the higher stratum. However, our mortality was substantially higher than that was observed in original study. So please notice that we have only a few patients that scored more than 13. That means the estimated mortality rate in the high score group may be inaccurate. This figure demonstrates the ROC curve and the area under the curve of three scoring, including MREMS, RTS, and MJAP. And the area under the ROC curve of MREMS represents the outstanding predictive performance than RTS and MJAP. While the statistical significance between the AUC of MREMS and RTS was observed, but no AUC difference was indicated between MREMS and MGAP. From this figure, the solid line that closes the dashed line in the diagonal direction. So it means that the observed probability corresponds well with the predicted probability. In other words, good calibration was observed in our dataset. So our research have a strange point is this is the first externally validation of MREMS and the first physiological score officially validated in Thailand. This score was validated in road traffic injury, which is a major health problem in Thailand. And the limitation, there are few patients in higher score more than 13, so the observed mortality rate may not accurate in this group. And finally, this study conducted in a single center, which have different characteristics from other trauma center in Thailand. So before implement this score in our country, further study should be conducted in other trauma center. The summary of this research is the MREMS is the excellent model for predicting in-hospital mortality rate of road traffic injury. And after MREMS had been externally validated in Thailand with an excellent result, this score could be used in our setting. Thank you for your attention.
Thank you very much, Dr. Nerolin. Our discussant for this paper is Professor Siddique, who's a trauma surgeon and general surgeon from Bangladesh. Professor Siddique, are you online?
Yes, can you hear me?
Yes,
Scott?
we can. Please go ahead.
Well, thank you, Dr. Narilin Pujagal, for an excellent presentation. You have gone through the study of the validation of this modified rapid emergency medicine score. So why did you choose this score only for the patients with road traffic accidents?
Because in our country, in Thailand, the road traffic is a leading cause of all injury, especially in a motorcycle or the motor vehicle.
Well, fine. Is it applicable for the patients with trauma due to other mechanisms of injury?
Pardon again, please.
Is it applicable for injuries due to other mechanisms apart from this road traffic accident?
We collect.
I want to mean that is it applicable for other types of injuries, other mechanisms of injuries apart from road traffic accident?
For my research, is applied only in road traffic injury because we collect only the road traffic injury patients, but we not yet collect or apply to another mechanism.
Well, thank you very much. Then you have excluded the patients who have pregnancy, isn't that?
The exclusion pregnancy?
Yes, you have excluded the patients who are pregnant. Why did you exclude these patients with pregnancy in this study?
Because it's maybe some vital signs that we got the parameter such as a heart rate that is maybe falls higher than the normal patients. I think it's maybe a false, maybe falls higher more than normal patient. So we exclude the pregnancy. And there is another factor such as have a baby or a limitation on resuscitation in pregnancy.
Well, thank you very much. Thank you, Scott.
Thank you.
Thank you, Professor Sadiq. Mrs. Paltridge, are there any questions on the chat or Q&A?
Yes, there is. How would you use this result of the MREM study to clinical use?
You mean the level of MRMS in clinical use at emergency department, right?
Yes.
Okay. We have a range. We have a range of score that will represent the higher score will be predict the higher mortality rate for in hospital. It means we have a cut point of range that if this range of score such as 2 to 5 is have a mortality rate as this percentage, and after we already calculated the MRMS from the six parameters, we can represent the mortality rate in percentage.
Thank you. That's the final question.
Thank you very much. And thank you very much, Dr. Nerlin, for your presentation. We'll move on to our next presenter. Our next presenter is Dr. Andrea Lee from Hong Kong. And the title of the paper is The Impact of Trauma Resuscitation Time on Patient Outcome in a Tertiary Trauma Center. Dr. Lee.
Good afternoon. I'm Andrea from Queen Mary Hospital of Hong Kong. Happy to share with you the topic on impact of trauma room resuscitation time on patient outcome in a tertiary trauma center. So in Hong Kong, 5% of mortalities are due to trauma. Even with all of the traffic and congestion here, a significant number of motor vehicle collisions still occur. Establishment of a trauma system is crucial to provide high quality care to these victims. And in Hong Kong, the primary trauma diversion system was set up in 2003, allowing any patient that fulfilled the trauma activation criteria to be directly diverted to 5 designated trauma centers around the island for immediate management. And this has successfully led to a lower mortality rate ever since. Trauma care is complex, and so in order to optimize the process, many hospitals like ours have standard operating procedures specifying which personnel of what qualifications need to attend trauma call, the roles of each person's, other trauma protocols, etc. Of course, we have the ATLS guidelines and training courses to teach and validate skill sets. Trauma center's quality needs to be continually evaluated, and this is done via trauma audit programs looking at outcomes such as trauma deaths, lengths of stay. Also, an important quality indicator is time. Time to intervention, time spent in the trauma rooms. Time is particularly crucial in trauma. We've all heard of the golden hour, termed by Cowley. And although the validity of this term has been questioned in recent years, the core principle of rapid intervention in trauma remains universally accepted. So this study aims to look at the impact of trauma room time on patient outcome in an optimized trauma room setting. This is a retrospective review of 10 years from 2011 to 21. Data was collected from the Trauma Registry of Queen Mary Hospital. Patients who fulfilled the trauma activation criteria, who were admitted to the hospital after trauma room care, and who had available ISS score after prospective data collection by a certified clinical assistant were included in the study. Exclusion criteria included pediatric patients of neonatal age, those with a severe head injury, those who failed CPR, and those who were transferred in and had already received initial management at an external hospital. So we had 969 patients in total. Patients were divided into 2 groups according to their injury severity score. Low was defined as a score of below 16, high was more than 16. So we had 500 patients in the low group, 460 in the high group, and then they were further subgrouped into short and long according to the resuscitation time. And from this study, the median resuscitation time in the trauma room was 58 minutes. So short meant less than 58 minutes, long meant more than 58 minutes. And you see here that larger proportion of the patients in the more injured group required a longer resuscitation time. Primary outcomes we looked at were hospital mortality. Secondary outcomes were length of stay in the hospital and length of stay in the ICU. Basic demographics of the trauma patients, they were in general more male trauma patients. Average age was around 50 in the high ISS group. Around 1/3 of the traumas occurred on weekends and public holidays. The vast majority were blunt traumas, and the most common mechanisms were RTAs and also falls. So these are the results of the low injury severity score patients, short resuscitation time and long resuscitation time. There was no major difference in the age and injury type. More patients in the long resuscitation group had hypotension, more occasions of delayed response by the trauma team. But these were not significant. There were slightly larger portion of weekend traumas as well in the long group, but again, this did not reach statistical significance. What was significant in the long trauma group were intubation rates, need for CT scan, duration in the CT suite, need for operation, and number of diagnoses. Similar for the high ISS group, long trauma room time was associated with need for intubation, chest drain insertion, CTs, operations, and increased number of diagnoses. On multivariate analysis, significant factors were need for intubation, operation, and number of diagnoses in the low ISS group, while in the high ISS group, it was need for operation. As for the outcomes, so in both severity groups, long trauma room time was not associated with increase in hospital mortality. And we're talking day 30 hospital mortality here. However, long resuscitation time was associated with longer hospital stay by 4 days in the low severity group and 7 days in the high severity group. Length of stay in the ICU is also longer by around a day in the low severity group and by 3 days in the high severity group. So, in conclusion, this study shows that longer trauma room time does not translate into increase in hospital mortality. However, it is associated with increase in length of stay and also with an increased number of diagnoses and increased number of procedural interventions such as intubation and operation. Hence, trauma room time may not be an accurate marker for quality of trauma care. On the other hand, a longer trauma room time rather than a reflection of poor trauma care may be more reflective of the complexity of the clinical condition, which in turn requires more diagnostic workup and intervention. Also, we do have in Hong Kong an older population in this locality. And as we've seen in the previous demographics table, our average trauma age for the high injury severity score is 50+ years old. This is higher than the general trauma age. These group of patients have more comorbidities, which might complicate the clinical condition, leading to more time needed for optimization. At the end of the day, time is always of the essence, but individualized trauma management is equally important. This is a very preliminary study and can be improved in many ways. First, I think we need to look further into why the trauma room time is long. We saw previously that it was associated with CT scans and time inside the CT suite, but how about time waiting for the CT? From personal experience, we do on occasion spend some idle time in the trauma room waiting for the radiology suite to open up for us. Another element that we didn't actually look at is time to intervention, or time from the last intervention to disposal. This means time waiting for a bed. Some studies have looked particularly into this factor, and it could be helpful for us as well. In recent years, the after-hour effect has also become quite popular. So in addition to looking at traumas coming in on weekends and public holidays, we could also look at those brought in during after hours when manpower is equally discounted. And as always, trauma care is multifactorial. Things such as trauma team familiarity, staff expertise, seniority, they all play a role. A lot of patient physiological factors weren't included in this study as well, but its addition could also lead to many confounders. One more thing to improve is consideration of using the risk-2 score, which has been proven to be even more superior than the TRIS score for this purpose. However, the risk score required extra variables, and some of our earlier data wasn't complete in this aspect, so risk wasn't used in this study. Finally, this is a single center study, which limits generalizability. So multi-center trial would be the next step. That's the end of my presentation. I would like to thank my supervisors for helping, and I welcome any questions. Thank you.
Thank you very much, Dr. Lee. I would like to welcome back, as discussant again for this paper, Professor Andre Das. Andre, are you there?
Yeah. Hi, Andrea. Thank you for your presentation. It's a real good, timely reminder of the importance of time in trauma, as all trauma surgeons know. My first question to you would be, how would you define resuscitation? Because you have used that as one of the big elements in your topic and you have not defined it. So what's your definition of resuscitation?
Right, so our definition for resuscitation in this study particularly is after activation of the trauma call, which means after initial assessment of the patient by our emergency department colleagues. And if the patient fits the trauma criteria, the surgeons are called down, ICU are called down, orthopedics are called down, and that's when trauma resuscitation starts. And the end point of that is when the patient actually leaves the emergency room for operation or for ICU care.
So as you have rightfully pointed out, this is the limitation of your study because of the usage of such a definition, whereas you're using the time in trauma room as your surrogate marker of this resuscitation. And if you're given a chance to redesign another study, how would you eliminate all these confounders? Maybe do a prospective study.
I would probably separate the trauma room time into two components. One would be from the activation of trauma call to the first investigation, for example, the CT suite, the CT investigation. And then the second trauma room phase would be back from the CT suite to intervention, for example, operation, and exclude the waiting time for beds, etc.
That's a nice answer. And my last question to you is, why do you use the so specific time of 58 minutes? Any reason for that, for choosing such a specific, a very unusual number, 58 minutes?
Right. The 58 minutes was the median time of our trauma resuscitation time in our hospital for all of the trauma activation patients. I did look at the literature. Actually, from the literature, the average trauma resuscitation time is a bit longer, a bit more than an hour. So 58 minutes, I suppose, is a fair score for our institution.
Okay, thank you very much. And back to you, Scott.
Thank you very much, Andre. Mrs. Paltridge, are there any questions on the Q&A?
There are no questions, Dr. Moores.
Okay, we'll wrap it up there for your paper. Thank you very much, Dr. Lee.
Thanks.
And we'll move on to our final paper of the afternoon, evening, depending on where you are, or morning. And that is, the final paper is by Dr. Randall Dialwas from Sri Lanka. And the title of the paper is Knowledge on Suturing of Facial Lacerations Among General Surgical Senior House Officers. Welcome, Dr. Alwas.
Good morning, everybody. I'm Randall Dialwas from beautiful country, Sri Lanka. Why we did this kind of study? Because we observed our patients who underwent suturing of facial lacerations. Some are having good aesthetic outcomes, while some are not. So we all know getting a good post-operative scar depends on multiple factors, but certainly we know technique matters. So we thought to investigate the knowledge on suturing of facial lacerations among general surgical senior house officers in Sri Lanka, who do most of the cases in our setup. We all know the face has many layers, from bone to the skin. A laceration, especially over bony prominence, is considered as a full thickness laceration. So it's important to suture lacerations in layers and to have good edge-to-edge approximation of the skin to have a good aesthetic outcome later on. So we randomly selected 21 senior house officers from 3 leading hospitals who have worked more than 5 years. Late Tracheostomy Hospital is the largest hospital in Sri Lanka for children, and another 2 leading hospitals in Western Province. Inquiring into their knowledge on suturing technique, suture material preference, their preferred suture material, suture sizes, and post-operative follow-up plans, so on. Surprisingly, we observed that only 23.8% of the sample is practicing the layered suturing technique, and 3 think that it gives best cosmetic outcome, while another two couldn't justify their answer. The majority, that is 76% of the sample, do single layer suturing, that is suturing the skin and underlying structure as a single layer. Among them, some think that this technique gives best cosmetic outcome. And some do this technique because they want to save their future time as they are running heavy theatre risks. And some have found difficulty in finding suture materials for suturing of underlying layers, and some could not justify their answer. When it comes to the size of the sutures, 71% of the sample preferred 5 knot as the preferred suture size, and 19% prefer 6 knot, and 10% prefer 4 knot as their preferred suture size. Majority prefer polypropylene as the preferred suture material, and 14% prefer polyamide. But whatever the size, whatever the material, all prefer to put simple interrupted sutures. Another important observation we noted is nearly 3/4 of the sample do not see their patients post-operatively, and only 1/4 see their patients post-operatively, but only during their first visit. None of them follow their patients and assess the scar and do reflective adjustments to their practice. When it comes to the suture removal, nearly 43% remove sutures on post-operative day 7, and 47% on day 5, and 10%, nearly 10% on day 4. But none of them refer their patients for occupational therapy to get scar therapy or advise on scar therapy. So we all know getting a good aesthetic outcome depends on a lot of factors. In our study, we observed that the majority of the participants practice a single layer suturing technique, giving a lot of justifications. Most of them are not based on scientific background. And another important observation was 3/4 of the population never see their patients post-operative, and none of them follow their patients and get a feedback from their patients or do reflective adjustments of their practice to improve their standards. And also none of them refer their patient for scar therapy or advise on scar therapy. In conclusion, we think that knowledge on suturing of facial laceration should be increased among doctors to improve the quality of care that we deliver, and they should see their patients post-operatively and assess the scar and do reflective adjustments to improve the standards of their practice. And they should be encouraged evidence-based practice rather than practicing routine or rather than practicing traditional things that they were used to practice. And handling receipt trauma and running heavy risk have significant negative impact on quality of care. Thank you very much. These are my references. Thank you very much again giving me this wonderful opportunity.
And that's a beautiful photo to wrap up that presentation. Thank you very much, Dr. Diallos, for that presentation. I'd like to introduce our next discussant, Professor David King, a vascular trauma surgeon from Adelaide in Australia. Professor King, your comments, please.
Dr. Moore, and thank you so much, Dr. Diallos. I think in trauma, we tend to focus on the more severe injuries, and we probably sometimes forget that what seems like a more minor injury, in fact, can still have quite profound, long-lasting physical and psychological effects on our patients, particularly perhaps the laceration to a child's face. Given the concerns that you found with regarding lack of standardization in technique, what would you suggest to try and improve technique and standardization across these general surgical SHOs?
Actually, Sri Lanka is a small country. And the Late Tracheostomy Hospital, the main center that we conducted this study, is the main center for the children in Sri Lanka. And also the other two hospitals. So we excluded SHOs who have experience. We selected only SHOs who have experience more than 5 years, and we excluded rest. So we considered all the SHOs actually in that particular centers who have experience more than 5 years.
Thank you. I suppose another question, these were general surgical junior trainees, and I think you're a plastic surgical resident, is that right? Do you feel that these sorts of lacerations should be managed more by plastic surgeons rather than general surgeons?
That's a very good question, sir. But I think because we have to think about the workload also, because plastic surgeons can't handle all the trauma, all the patient lacerations in the country. So actually, but we have started, after this study, we have started kind of intervention, because in Sri Lanka, in postgraduate training, all the general surgical residents are doing a plastic surgical appointment. During that appointment, we have planned a very good program to teach them how to suture facial lacerations properly. So, so we have planned a lot of other interventions to improve the quality of suturing in Sri Lanka.
Thank you. One last question. You commented on the depth of lacerations and the structures that are lacerated. Do you think that the length of the laceration has an impact on whether you would choose a double or a single layered closure technique?
I don't think so, sir. If you go through a literature survey of the references that I found, it's mainly depends on the depth, and length also matters, because it's a very especially when it comes to the face, if the laceration going perpendicular to the langus line, skin tension lines, it matters. But definitely more than the length, depth is matters, because we have observed a lot of patients who are having stretch out scars and also depressed scars, especially when they are suturing the deep layers, especially the muscle. So that is the main observation that we do this study.
Thank you very much, Dr. Dalwis. Thank you. That's great. Thank you, Dr. Damore.
Thank you, Professor King. Mrs. Paltridge, are there any questions from Q&A or chat boxes?
Yes. So what is the way you use to randomize the selected SHOs?
Actually, I answered this question also. We didn't actually. We have to consider all the senior surgical house officers in these centers who have experience more than 5 years.
Okay, thank you. And was SSI studied or observed?
I beg your pardon?
The question that's been put in the chat is, was SSI studied or observed?
I think
I'm not sure that
no.
is that for someone else?
Site infection.
Surgical site.
Surgical site infection.
Yeah,
thank you.
I know. It's out of house scope. No, we didn't consider.
That's it. Thank you. That's it.
Okay. All right. Thank you very much. And thank you, Dr. Dalwis, for your presentation. That brings us to the end of our resident paper competition for this year. And before I send everybody offline, can I just say many thanks to our presenters, who clearly have put a lot of work into their papers, into their research. And the quality of the paper competition over the last 4 or 5 years that I've been involved, for sure, has really increased dramatically year by year. So thank you again to all of our presenters for your efforts. I'd like to congratulate you on some great presentations, but also your answering of questions, which are just thrown straight out to you, was done very well as well. So thank you. I'd also like to thank our Indian hosts again, Professor Misra and Professor Gupta and their technical team for pulling this together. I think there was a couple of like a couple of minor glitches, but it has been fantastic. And trying to do one of these things with many moving bits and live discussants and live questions and answers is incredibly difficult. I think you've done especially well. So thank you again to the Indian organizing team for really putting together a wonderful presentation opportunity for our trainees. Many thanks to our judges as well, who have been working hard in the background. And of course, our discussants have done an amazing job as well of pulling out some very interesting questions based on your presentations and on your abstracts. So thank you to our discussants as well for their efforts. Judges, if you could please return your scores to me and to Mrs. Dunstall. We'll do the number crunching. I've sent you an email on that already. And of course, our announcement of winner and runner-up will be tomorrow during the virtual education session. So please, all of the presenters, I hope you're able to attend. And I also hope all of our discussants, all of our judges, and all of the rest of the audience that's here today will be able to join us again tomorrow for the virtual education session. It starts at 9:30 India Standard Time, and that'll be a little bit different for where the rest of you are, but please check your trusty time zone app, and that session will run between 9:30 and 11:30 tomorrow morning India Standard Time. Unless anybody has any reminders for me of anything else, and I'll just double check all the different moving parts that I have to see if there's anything I've forgotten. Not there. Not there. So again, thank you, everybody. We look forward to seeing you tomorrow, and please enjoy the rest of your day, be it morning, afternoon, or evening, depending on where you are. Thank you again. Good evening.
For conducting so well presentations.
You're welcome. Thank you.
Thank you, everyone.
Thank you so much. Thank you.
We'll see you tomorrow.
See you.
See you, Scott. You did a great job. See you tomorrow morning.
Yeah. Thank you. Bye-bye. We'll see you tomorrow.
Bye-bye. Bye-bye. See you tomorrow.
So nice to see so many familiar faces. Hopefully we get to catch up in person again sometime soon.
Definitely.
We are live. Very good evening, good afternoon, and good morning from wherever you are listening to us. And after a wonderful session so far, now we are about to begin a new session, which is, I think, the most important session of today's talk. In the remaining part is the trauma nursing session. And as far as the importance of a nursing colleague is concerned, he is as important of a team member as any other member. So conduct this session, I would like to request our respected chairperson, Dr. Seema Sachdeva. I would like to request our respected chairperson, Dr. Seema Sachdeva. Dr. Seema Sachdeva is a faculty in the College of Nursing at AIIMS, New Delhi. Chairperson, Dr. Seema Sachdeva. Dr. Seema Sachdeva, welcome, ma'am. A faculty in the College of Nursing at AIIMS, New Delhi. Tech team, there is so many echo. Dr. Seema Sachdeva, welcome, ma'am. A faculty in the College of Nursing. Hello.
Sir, I will be alone in this as a chairperson, or
yes, ma'am. Yes, ma'am. So you can start. You can start the session. We are live now. You can start the session, and you can introduce our first speaker, ma'am.
Sir, will I have a slide?
Yes, ma'am. We are displaying the slide. Tech team, please display the slide.
Am I audible, sir?
Yes, please continue, ma'am.
So a very good afternoon to all the delegates and the organizing team. So the today trauma nursing sessions, we are going to have the first session by Professor Suresh Sharma sir. Sir is working as a principal in College of Nursing, AIMS, Jodhpur. So the next slide about sir's contribution and achievement.
That's all. Sir, please, Professor Suresh, can you start? Please start your talk.
Sure. Thank you so much. Just give me a moment to share the slide and then I'll begin.
Sure, sure.
No, it's not good. I'll try to improve.
Hope you can see my slides.
Yes, sir. Very well. Please continue.
Perfect. So at outset, I would like to express my heartfelt thanks to all the organizing team of Trauma 21 virtual conference. And I'm grateful for all the people who have joined to listen to this talk. And with permission of chairperson, I would like to talk today about the trauma nursing training in India, current status and way forward. If we look into the WHO's concept of what are the steps of trauma care management, in that we all appreciate that it starts with phase 1, that is triaging, and then phase 2, the primary survey, then resuscitation, secondary survey, stabilization, and transfer. And at the end, at phase 6, we require definitive care. Above definitive care, any healthcare professional, if preliminarily trained into trauma care, can take care for triaging, primary survey, resuscitation, secondary survey, stabilizing, and transfer at a right center. Nurses can play a very important role in all the 5 stages, and at a 6th stage, they can partner with the advanced trauma center with the doctors to provide a definitive care. However, if we look into the nursing education happening for nurses who are involved into trauma facilities in India, is at 3 different levels. We have a diploma nursing program, which is a 3 years program. And in that program, we teach for 4 hours. And we just talk about emergency more and one topic about trauma and accident. In BSc nursing, also there's a unit, 4 years program, there's a unit in medical surgical nursing for 10 hours. And there we talk primarily about emergency disaster nursing and a very little about the trauma. Medical surgical nursing master's course we have for 2 years, and there we teach them for 10 hours in trauma and emergency. However, no separate specialty course in trauma and emergency nursing happening in India till today. If we look into trauma nursing education, as I said, that in first time Indian Nursing Council in 2006 included a dedicated unit on emergency nursing in BSc nursing curriculum. However, trauma is still not taught separately. If we look into this curriculum, medical surgical nursing 2, which has a unit for 10 hours, says emergency and disaster situations, nursing management. And in this unit, there's a one topic called as polytrauma, road accidents, crash injuries, and wound. And if we look into this 10 hours unit in BSc nursing program, there are around 30 topics. So this topic gets 15 minutes to talk. And I think this is injustice in a country where large number of deaths are happening because of road traffic accidents and fall and other traumas if we include. If we look into the trauma nursing training happening in India, we are fortunate that advanced trauma care nursing course by a Trauma Nurses Society from US has been developed. And this program has been brought under the aegis of Indian Society for Trauma and Acute Care, under which we are having this conference today. And kudos to Professor MC Mishra, who was a former director of AIMS Delhi, and a course director, Mr. Suresh Sanghi, who has taken pains to bring this course in India. They started at AIMS Delhi, and now significant good number of centers, that is KJMU Lucknow, AIMS Rishikesh, AIMS Jodhpur, in this month only started the first ATCN course. It is Jaipur Mahatma Gandhi, the Air Force Hospital in Bangalore, and other centers are taking up this course for nurses. And we are thankful for Society of Trauma Nurses from US, and we are thankful for Indian Society of Trauma and Acute Care for bringing this course for nurses in India. There are total 28 certified trained faculty for ATCN course in India today, and we have greater than 400 certified ATCN providers in the country who are working in different tertiary care institutions. If we look into trauma education, which has brought up, if you look at website of Narayana Nursing College in Bihar, they started a post-basic diploma in emergency and disaster nursing. This course is developed by Indian Nursing Council, which is a one-year program, and a student who have done a diploma or BSc nursing can take up this program. MGM Institute of Health Sciences in Navi Mumbai also started this program. Maybe other institutions which I'm not aware have started, but unfortunately, there's no takers for this course. Why there are no takers for this course? Once this one-year residential course has been started in a country like India. The problem is, if a nurse comes and takes this course, spends extra 1 year, she is paid nothing. She has to pay from her pocket, take this training, and when she go back to the hospital, either government or private, she is not paid anything extra than with having this additional qualification. So that is the major problem, neither a specific employment nor advanced perks and privileges. Therefore, they are not coming to take this course. There are technological courses started in emergency and medicine and trauma. If you look into Rajiv Gandhi Institute of Health Sciences, Bangalore 2020 curricular regulations, they started BSc in emergency and trauma care technology because people are required. Nurses are not taking this as a specialty because of many bottlenecks. A BSc in accident and emergency care technology was started in South India in 1819, one of the university. And in this course, this is a 3 years course, a graduate level course, a degree program, where 10+2 candidates can be recruited directly. And people trained by this program, when they went to private hospitals, government have no employment for them. They had no additional thing in their hand. And that's why they have not been accepted into system very well. So we are not very successful creating this as a specialty into nursing and allied paramedical disciplines other than medicine. And not many takers again for this course because employability drives the people getting inducted into this course. What are the recent developments for trauma nursing education in India? AIMS Delhi organized a joint meeting with nursing faculty of all INIs in July 2018 to design a curriculum for starting MSc in emergency nursing course at different centers in India. AIMS Jodhpur and Rishikesh are in process at the moment for starting MSc trauma and emergency nursing course. At AIMS Rishikesh, when I was a principal till 2020, we already took approval from our academic board to start this program to provide skilled nurses in trauma and emergency nursing, and also which is directed recently by Nursing Division of Ministry of Health and Family Welfare, that we require to begin these courses in at least in AIMS institutions, the AIMS Delhi, and then 6 new AIMS we started in 2012, and gradually that these can go to the other phases started in All India Institute of Medical Sciences in different parts of the country. Now, but still they have to be taking up, and they have not yet taken up. There may be some of the challenges, but we have opportunities within that. What are the opportunities? We need to upskill existing nurses working in trauma and emergency facilities, either bringing the ATCN course mandatory for them and government pay for them, funds for them, and to have a trained and skilled trauma and emergency nurses in country, which can make the outcome of any trauma patient very effective because it's a teamwork. From trauma where it is happening, pre-hospital team, the triaging team, the team which is working in trauma and emergency, and then team working into trauma ICU where the definitive care is required, or operation theater where the surgeries are performed for trauma patients. And to develop and implement trauma and emergency protocol-based protocols which are based on local resources and our needs, because the protocols which exist in US and UK may not be fit into Indian setup. To develop quality nursing indicators for trauma and emergency nursing so that we can have quality assurance models for our own country, and that can become model for other developed country in the world. But we have challenges. That's a region like after 75 years of independence, still this has not become a specialty into nursing. No national plan for development and implementation of trauma emergency nursing courses. We talk about it, but to effectively implement these courses, we must have specialty positions created for nurses. They are paid differently. Then only people will come and take these courses. Lack of licensing for nurses with specialization, any specialization in nursing. Nurses are still licensed as a registered nurse or registered midwife. Additional qualifications are enrolled with these registrations, but there's no specialized registrations are happening like MD or MCH or DM in medical sciences. No special employment opportunities and salary benefits for nurses with specialization, including trauma and emergency care. So then who will take these programs? Lack of availability of trained trauma and emergency nursing faculty. So if there's no hand from where the ag will come, and this is a vicious cycle. But what is the way forward for all of us? We need to begin from upscaling the existing nurses who are working in trauma and emergency by bringing ATCN program or kind of ATCN program, which we can tailor-made, or we can offer them fellowship program, as Madam Rati Balachandran was speaking one day from Ministry of Health, that we must make some program for trauma nurses to train them. And then we need to retain them into trauma and emergency. They should not be rotated at other place. And that how we can do by offering specialized designations and salary benefits. Creating specialized job for trauma and emergency trained nurses in government sector, and then definitely private sector will understand the uses of this and they will do it. Developing and starting trauma and emergency courses for nurses in India, considering Indian resources and needs. Nursing faculty development in trauma and emergency nursing through their training at national and international level. Lobbying for specialized licensing for nurses trained in trauma and emergency nursing in state and Indian Nursing Council, and developing endogenous trauma and emergency nursing protocols and standards, and focusing on continuous quality improvement through monitoring and revision of trauma and emergency care indicators. If I summarize, it's a high time to have specialized training and employment in trauma and emergency nursing in country, and specialized licensing, employment, and pay is the key to motivate nurses to take trauma nursing education and career. We also need to formulate a nursing division within ISTAC and develop a cost-effective trauma nursing courses and protocols under that banner, because we have now 400 ATCN trained nurses and we have around close to 30 nursing faculty who are taking ATCN courses, and they have interest in educating and taking ahead the education of trauma nursing in country. With this, thank you so much for having a patience for listening what I have said in last 15 to 18 slides. If any questions, I will be happy to answer those. Thank you so much.
Thank you very much, Professor Suresh. It was such a nice elaborative talk to give us a comprehensive idea about the grim status of the trauma nursing in our country and the immense need to develop such programs. Thank you, sir. Thank you very much. And just one question, actually, I would like to ask if AIIMS Jodhpur per se is taking any lead to develop such kind of programs under your leadership.
Yes, as I said that I was a principal at AIIMS Rishikesh for last 8 years. And there we developed a curriculum which was developed at AIIMS Delhi during that meeting. We took it up, we built it up, and we took approval from our academic committee. Then in December 2020, I shifted at Jodhpur, and we are in a process at Jodhpur for getting approval of same program by adding few more things. In addition to that, we have made a nearly mandatory in Rishikesh for all the nurses to take ATCN program who are working in trauma and emergency. And we are again motivating nurses who are working at AIIMS Jodhpur in trauma and emergency to take ATCN program. And kind of ATCN, a small capsule course we run for all the undergraduate students who are taking BSc Nursing Honors program at AIIMS Jodhpur. So very soon we'll have a master's program in trauma and emergency nursing at Jodhpur. And we are inculcating the trauma training, at least basic trauma training, where the undergraduate nurse who is passing out from AIIMS Jodhpur understands that what is primary survey, what is secondary survey, what is ABCDE, and how she should handle and transfer a patient to right center. This is our commitment to with ourselves.
Thank you, sir. And as sir, you said in your talk that there is lack of motivation and kind of taking them forward by giving them financial benefit or any other kind of benefit. Do you think that you will be able to implement such kind of policies at AIMS Jodhpur or any other AIMS? Basically, would you recommend them that such any specific policies to kind of promote the trauma nursing courses and trauma nursing cadre should be applicable? Your thought?
So Dinesh, we had several meetings at Ministry of Health and Family Welfare, Government of India. Dr. Rati Balachandran unfortunately could not join, but we were discussing in a meeting around a month and half back that now it is a high time. We cannot recruit nurses as a registered nurse in every section. We must categorize the positions for nurses for every department, be it a CTVS, be it a cardiology, be it a gastroenterology, be it a trauma emergency. And those nurses who are employed in trauma and emergency must have that specific qualification tagged to it. If we can't meet at a moment, because we don't have those number of courses, but courses will come up once we'll make it mandatory. So these talks are going on to create a specialization cadre in nursing, because what the cadre we have now, nurse joined as a registered nurse, she becomes senior nursing officer, she becomes ANS, and then she leaves the patient care, she goes towards administration. That's a very bad story. Like me, I started my career from base and now I'm totally away from patient because I'm a nurse educator and more of administrator being a principal at a college. But in medical science, you see a faculty who become with the time collects the experience, goes back to the patient. So in nursing, it's a time to create a specialized cadre. So people who want to be in this cadre, there's a career progression within that specialization, and they continue serving the patients with that. And with this specialized cadre, the pay perks begin higher. Positions are retitled, like we say, clinical nurse specialist in trauma care. This is the title which BEST uses. And their career can start equal to the ANS into the routine care. So the nurses who don't want to do specialization, they can be registered nurses, can work in general medical, general surgical units. And nurses who want to be with specialization, they can work as a clinical specialist nurse, then advanced clinical specialist nurse, nurse practitioners, and senior clinical specialist. This is the cadre they follow, rather than getting into administration, going away from the patient. So these are the talks, these are the thoughts. Government is very keen at the moment, and we are hopeful that this will happen. So this is a matter of policy at the national level, and I'm hopeful that it will happen.
Yes, sir. Thank you. Thank you very much. And I totally second with your thought process that there should be, now it is a very high time to India to realize that there should be a specialization within the nursing cadre also, rather than following the single hierarchy, as you said. If there are any questions, more questions from the panelists, we can take that to Professor Suresh. Okay, thank you, sir. Thank you very much. Please be with us with the rest of our talks. And I invite next speaker, Dr. Rajni. She is the Assistant Nursing Commandant in the Varanasi Cancer Hospital. Dr. Rajni.
Yes, sir.
So Dr. Rajni is the Assistant Nursing Superintendent in the Homi Bhava Cancer Hospital and Mahamana Pandit Mahamana Manviya Cancer Center at the Varanasi under the Department of Atomic Energy, Government of India. Dr. Rajni, the stage is all yours. Please start.
Thank you, sir. Sir, I am not able to share my screen now.
Tech team can please help Dr. Rajni.
Ma'am, you can share now.
It is showing error image. I think it has to convert it in PDF.
Ma'am, are you using mobile?
Yes, yes.
Do you have any system, or you can send your PPT to us?
Yeah.
So till the time Dr. Rajni is sorted out, can we have the next speaker? Brigadier S.V. Saraswati fortunately has joined us. Ma'am, can you hear us?
Yeah, I can hear you.
Thank you very much, ma'am, for joining us. And
can you hear me?
Yes, ma'am, we can very well hear you and very well
Now I would
see
like
you.
to share my presentation.
Yes, ma'am, please carry on.
So should I directly do it from the Google Slides?
You can do, or you directly from with the share screen option.
Yeah. Okay.
Yes, ma'am.
Yeah, please help me. I'll share the screen.
Yes, ma'am. I think this screen belongs to ma'am, or it is the from tech team.
This is my screen.
Okay, great, ma'am. You can start, please, ma'am. Thank you.
This one is introduction from us, sir.
Yeah.
No, ma'am. Ma'am, you have not shared. The screen displayed is from the tech team as your introduction slide.
Okay. 1 minute. Where is the option for sharing screen? Yeah, I got it. Now? Yeah. No, I think I will. I'm on. Let me.
Yes, allow, ma'am. Please allow him.
Yeah.
Yes, we can very well see.
Can you see now?
The slide is not yet came. Yes.
And now can you?
Yes. Now we can see.
Yes. Now can you see my presentation?
Yes, ma'am. Please.
First of all, thank you very much and very good afternoon to all of you, and thanks for having me here. I'm really honored. My topic today is on the mass casualty of a triage of the casualties, but it's a very vast topic, so I'll be just giving you an overview of the topic. Can you hear me, please?
Yes, ma'am. We can very well hear you. Please carry on.
Yeah. The mass casualties incidents, they result from multiple causes, including transport, mass gatherings, armored conflicts, terrorism, and biological, geophysical, and hydrometeorological disasters, as you see in these pictures. And when you look at the global maps, globally, the incidence and the nature of MCI, I'll be referring in my talk about the mass casualty incident as MCI. The MCI varies, and nature of the MCI depends on, and that is an expectation that it depends upon where has it happened and what is the level of the MCI. And also, it is also predicted that in future, there'll be more of hydrometeorological disasters because of the climate change that is going on. And in this map, you can see that almost all the continents were exposed to natural hazards sometime or the other. And when you look at the fatality ratio and ranges in due to natural disasters, once upon a time it was 10,000. Now it has already risen to 100,000. And most of these disasters are 83.9% percent is happening because of the accidents, windstorms, earthquakes, drought, floods, and all those things, such things. And not only that, after 2000, the man-made disasters have increased, and they're adding in the rising numbers, apart from the deadliest disasters and the mega disasters. What happens when disaster or a mass casualty incident happens. It happens, the minute it happens, there will be totally mass panic. So what happens, how to control the panics? So there is a system which is devised by every city, every state, and every country based on the guidelines given by the World Health Organization for disaster management. See, these are the group of units and organizations and sectors which work jointly during a mass casualty event. That is based on the pre-established procedures, maximization of use of the existing resources, and multi-sectoral preparation and response, and also based on the strong pre-planned and tested coordinations. Who are the stakeholders? The stakeholders are the city, district, state, and the country authorities. Depending upon their involvement depends upon the level of the MCI, level 1, 2, 3, 4, 5. There are 5 different levels of MCI. It depends upon the involvement. So who are the responders? Responders are people. They could be volunteers, fire staff, police staff, special units, emergency technicians, and these people are deployed either on site or at the collecting area or at any other area where the patient movement is involved. The action which is very important for these people is just to transfer with consideration of order of priority. So what is pre-incidence preparedness? Timing and nature of MCIs are very unpredictable. These incidents require sustained response by the healthcare systems. There need to be standard operating procedures in place. Responders should know that their role. There should be mock drills continuously, and there should also be earmarked specific centers, hospitals, designated hospitals with surge capacity and medical bricks. And in case of CPR&E, you also have to have the PPE, antidotes, in addition, detection kits, portable decontamination units, and so on. The incident management, exactly the incident where it happens, how is it managed? See, before managing, you have to assess the situation. There can be very few casualties or they may be in hundreds, but resources will be very few in the beginning. So it also affects the local hospitals in the process because they are already burdened with the overload of the patients. So as I said, the management of this incident depends upon there are different variables, depends upon the type and level of the MCI. See, the response depends on the place of incidents and the population that is affected and type and cause of the incident and whether it was accident or it was an attack, or are there more incidents going to happen, or do you have any advanced information about the incident? So now the triage, even the triage differs, different levels. It could be on site or it is little away from the site. And how are the weather condition? If it is pouring rain and it is stormy condition, you cannot have a proper triage immediately. There will be so many obstacles from the natural environment also. You also have to know the communication and the connectivity available. And also the main basis is depending upon the urgency of the victim's status and the survival chance or likelihood and the care resources available with you. The medical people will take care of the first aid, advanced medical point, reaching the patient to that place, and also for the further care facilities. The responders will concentrate on the evacuation and transportation of the patients. The main objectives are like having quick identification of the victims, immediate stabilization, and see that life-saving measures are carried out. If there are surgery is required, they are dispatched to the surgery area as quickly as possible to reduce any further damage. So here I will just explain to you in an animated form what happens when such incidents occurs. So I take an example of a football or some playground where you're seeing 3 circles here. This is the inner circle and there are tracks or players sides, and the green circle is the seating points. And there are so many out exits, or you also may call it at this juncture as escape routes. So here a blast occurs. Then what happens? Automatically, the alarms are raised and there will be a random movement of the community in panic. So what happens? Then the security people who are responsible for that particular zone, area, or district, immediately they are at the site and they cordon off this area of the blast, because nobody should reach there, and also they have to create escape routes away from the blast area. But then the escape routes are used to remove people from the stadium to outside. Now, by now, the disaster relief force has already reached, and these people form what is called the perimeter markings. So they devise perimeter marking depends upon the blast. What kind of a blast is it? Is it a nuclear one? Was it a chemical one? So depends upon, because there's difference in marking of perimeters for a nuclear blast and for a chemical blast. Okay? I will be explaining it in my next slide. See, these people, they give the marking as a hot, warm, and cold zones. So only the trained people have access to enter these zones with the proper protective gear. And now, by now, the casualty have been evacuated. Suppose if this incident is associated with a nuclear or a radiological or a certain blast, then the disaster relief force also establishes the decontaminated sites and also a first aid post close by. And then the casualties are taken to a point called CCP. It is a casualty collection point. So from the casualty collection point, these people are then taken over by another team of people. See, the same person who is at the blast site, he cannot control the people, the victims and their management in the other side. Now, the casualty has reached to another side where the QRT, quick reaction team, and the quick reaction medical team are waiting. They receive these casualties, and then they further, if required, they will do the triage and dispatch the people accordingly to the nearest healthcare facility, that is called advanced care medical point available. See, this is for explaining to you how, suppose here is the blast which has occurred at 25 miles, that is 40.5 kilometers distance. Also, the human beings are affected. All the glass panes of the buildings and the high-rise buildings and houses are shattered. And at 15 miles of distance, also damage is severe, and that comes in the yellow zone. So until unless you are trained in the disaster management, you cannot enter these zones without proper protective gear, and the disaster management teams also will not. So volunteers will be mostly used out in the outer areas. Suppose you get to know that there was a blast in this area, you should know the geography of your own city. How far is it from this place? And as far as possible, you shouldn't just rush in to save somebody, because you have to have the protective gear. If you are not protected, you cannot save the victims or you cannot help anybody. You should help yourself first. Then at the site management is basically done by using the two components. The encompass procedures used to organize the disaster area in order to facilitate the management of the victims. The procedures which are used is, number one is the alerting process. There should be an alert, the announcement, siren, so many, all these things are used to alert people not to gather, because it is very difficult at such incidences. There's a lot of crowd gathering, and you have to concentrate on having the first aid areas nearby, and also the safety and security of people. Is search and rescue of the victims, is there any feasibility? What is the nearest care available? And if at all you have to evacuate, you have the transport, you have the roads to move the patients to other places, at least to an emergency management center. And what about the action by the medical team? Medical team will take care of the triage. It will look into the BLS if required, and also send the patients to the nearest advanced medical post for X-rays or small surgeries, suturings and such things, and also dispatch patients to the trauma centers or other hospitals. And apart from that, the team also collects certain samples in case of CVR and injuries, and also document the dead bodies and they look into the dispatch of the dead bodies. So this I don't have to explain very clearly to you because I am talking to very this thing well-known and vibrant audience who are already into trauma and associated topics since decades. So the common tags we use are red, yellow, green, and black, as you all know. And the scenery somewhat looks like this, the entire scene. So here is the blast which has happened. So here are the victims are being moved to the collection area, and from there they continue BLS. If required, they are shifted to the triage area, and from there to the treatment area. So priority 1, 2, and 3. The entire orders for moving and people to get involved is all done at this place. This is called the control point. The control point at this site. There will be another control point after the patients have been sent to the advanced medical post. But it is very difficult to manage these MCAs, even if in a group of 100 people. So why it happens? Because people are not aware whom they should listen. Everybody will be giving instructions and they expect everyone to follow the instructions. So there has to be a person who is holding the entire team together and leads them to a place where they have to do and what they have to do, till the medical teams and the other helping teams who are already trained in such things arrive, at least in the beginning. So people should also know where is the central command point. It has to be having an identification. And sometimes there is lack of communication between agencies who are trying to help save the victims. And sometimes there will be conflicts, there will be priorities. You take these people first, you take those people first, there will be conflicts. And sometimes there is no perimeter establishment. So people don't know which is the yellow area, which is the red area, which is the cold area they can go, they cannot go. There will be no perimeter establishment. And there will be large crowds of people who will not listen to you. So there will be media involvement, there's a political and involvement, and there will be traffic jams. And overall, you have inadequate resources. So it is a Herculean task to manage the mass casualty incidents, at least if you do not have a system in place. So based on the World Health Organization guidance, many cities, as I told you earlier, cities and states have their own set disaster management procedures and people designated to do what at that stage. So basically there are 3 types of approaches. The first one is the swoop and run, which is used only for small, a lot of victims who can be picked up and transferred to the hospitals. And the classical approach is the first responders who do the maximum things at one stable place. And immediate action is not done at that place. Whereas the mass casualty management approach, which is designed and it is existing, time-tested, is mostly used because it is pre-established procedures are there for resource mobilization, for field management, and also hospitals are designated to receive the patients in a short time. So why it is the best? Because the responders are trained. The links are incorporated between the field health and care facilities. There is a earmarked control and a command point. So people know whom they should listen. And there is multi-sectoral response of traffic police, superintendent of police, the fire people, all those people. Then depends upon the availability of the human and material resources. More people you will need if the level of MCI is 4 or 5. You will need less people if the level is less. So whatever it is, it depends mostly on the availability of the help from the outer sides. So as I told you earlier, these in the planned management casualty system, there are people designated for every process that happens. The incident manager, the safety officer, there's the operations officer, patient care manager, there's a media spokesperson, and there's a communication officer. There's the information officer, because we will have to inform the situation at the place to the higher authorities, because we need to seek help from them. Without the help of the government and the other authorities, we cannot do anything at the site. So you have to have a checklist the minute you think of having a place very close to the impact zone to shift the patients. You have to assess the situation, how many patients I can shift, is it safe or secure to shift? And then does this place have the radio communication facilities? Is crowd and traffic control easy or feasible at that place? and is the search, rescue, or scoop operations feasibility is there, or the facilities for triage and the stabilization, and also for the controlled evacuation. So in this plan, when you see as in the diagrammatic representative, it look like this. This is the perimeter which has already been cordoned off, and this is the work area, impact zone is this, and the people are not allowed to enter the red zone, and the way the blue lines are put, this zone is restricted, only certain people will be allowed to enter. So from here, you are taking the victims to the after triage to the advanced medical care point under the control and command of the boardroom, wherever it is located. Then they are evacuated to the, with help of traffic police, evacuated to the necessary hospitals for the necessary emergency care. So even while casualty evacuation, you need to be very, very concerned about the security and safety, because people who are working for you, the volunteers, even the volunteers have to be safe, because if they are not protected well, they cannot help other people. So there has to be crowd management and traffic control, because the massive crowd entering at the place of a massive incident, they will not allow you to do anything for the patients, because they all will be looking for their relatives, their friends, whoever have been injured or things like that. So you have to have a very strict crowd and traffic control, and especially the protection of workers. As I said, they are undergoing a lot of stress, and you also have to have a way to free flow of the victims to the hospitals, and also availability of the resources coming from outside to the impact zone. You need to have specialized ambulances, and to continue the BLS, ventilation, and to continue giving them fluids. And in case of CBRN, you also have to have the facilities for a field lab to carry out sample collection and decontamination of the victims, and also the vehicles. So when we all are busy in managing the mass casualties at the incident site and the advanced medical care point, what happens to the external environment? What happens to the city? The other measures, whenever such incidents happen, the government automatically has plans to take care of the other buildings like airports, buildings, not all buildings, government institutions and hospitals, schools and other establishments. It automatically works. The evacuation of people from the impact zone to the advanced medical care point is known as the rescue zone. Here you are rescuing people. You have to search, rescue, give first aid, immediately transfer them from the pre-hospital organization to the hospital organization at the earliest. So mass casualty incident rates are not being explained in detail, because we are aware of.
I'm sorry to interrupt you, ma'am. I'm really very sorry to interrupt you. We are running short of time, so if you can please go through.
It is over. It is over.
Thank you. Thank you.
So it is over, and I just want to sum up is we can deal with the MCs only if we have constant state of readiness and emergency preparedness in place and multidisciplinary expertise. We also have to educate and sensitize the general public on environmental issues and the need to contribute for its protection, because there is a need to have smart cities like this with all the facilities, and to view the accident site in such a way using the latest IT technology, and to guide from a remote area to the people to what they should do next. Thank you very much for having me here, and Jai Hind.
Thank you. Thank you very much. Thank you very much, ma'am, for giving such an elaborative talk on the intricacies of the triage and mass casualty event management, not only for the medical perspective, but other logistics also. So thank you very much. And the house is open for any queries, questions, remarks from the other panelists. So thank you very much. Thank you for giving us your prestigious time. And we would like to have you in the next session also. And till the time we move on to next talk. Dr. Rajni, I think you are ready now.
Yes, sir. Yes, sir. I'm ready.
Please go ahead. Thank you.
Sir, is my slides are visible?
Yes, ma'am, they are visible. If you can do on presentation mode, then that would be great.
Sorry for the inconvenience.
From right lower end. There is sign of these 3.3 signs. Yes. Little bit more right. Just left to 53%. Just left to 53%. This 53% you can see on the right lower end.
Now it's okay?
No, it's become more minimized. You can see the 53% written.
No, sir.
On the right lower end of your screen.
No, sir. Sir, give me some time.
I think you have minimized it, ma'am.
So 1 minute.
There is window which is opened, and there is one cross sign and one minus sign, and in between there is a box sign. Can you see that? Yes. Now you can see 48% written. 48%. No, don't click that. Don't click that. 48% written just here. Go a little bit left. 48%. Next, left. Go a little bit more left. No, not so left. There are these 3 signs. One box, one 4 quadrant. Now it's okay. You can present. Thank you. You can present. Thank you.
Okay, sir. Extremely sorry for the inconvenience. So
please go ahead.
Very good afternoon to the organizer, respected Suresh Sharma sir, Suresh Sanghi sir, Dr. Dinesh. So I'm here to present on timely care of the injured. So if we go through this data, so injury kills nearly twice. So if we go through this data, so here we can see that injury kills nearly twice as many people each year as HIV, malaria and TB combined. So despite of this burden, the funding of the care of the injured represent less than 1% of the total development assistance for the health. This is data by WHO and it is really disappointing. So injury deaths, what and where? So what means here injury accounts, if we talk about the injury, so road traffic accident accounts for the 28% of the total injuries, followed by suicide, falls and homicide and so on. So, but here my experience in trauma center here in India or Uttar Pradesh, if I say, it follows by road traffic accident, followed by falls from height, physical assault and so on. And where it occurs are street, home, school, sea, lakes, river and workplaces. So road traffic injuries alone account for 1.3 million deaths per year globally. Fatality rates in low-income countries nearly triple those in high-income countries. So if we see that in comparison to the high-income countries, low-income countries and middle-income countries are really very much high. And road traffic injury are the leading cause of death for those who are aged between 5 to 29. This is really means the productive age and the, are highly compromised. So if we talk about the mode of injuries and the number of patients get injured, this is the epidemiological study from India only. So it is two-wheeler accident followed by car accident, fall from height, pedestrian, hit by animal, personal assault, gunshot injury, fall from moving train and moving bus. And the pattern of injury is head injury. The ratio of head injury with associated injury is the highest. A study from PGI Chandigarh shows that the head injury patients, 70% of the head injury patients do not reach the hospital during the initial time. That is, we also say it as a golden hour. So that leads to very poor prognosis in trauma. So pattern of injury, we are talking that head injury with associated injury, followed by chest injury, which comprise of pneumothorax, tension pneumothorax, cervical spine injury with or without neurological deficit, lumbar spine injury, extremity fracture, maxillofacial injury, other injury, mangled forearm and foot, cardiac injury, crush injuries, and foot. So this is the data, state-wise accident death during 2019 by this is the data which shows that Delhi, Uttar Pradesh, Bihar, Madhya Pradesh, Gujarat has above 15,000 of accident death during 2019, and this data is increasing. So the golden hour, the time following the traumatic injury when the prompt medical treatment has the highest likelihood to prevent the death. So the golden hour term to represent the urgent need of the care trauma patients. It implies that morbidity and mortality are affected if care not instituted within 1 hour of injury. So the hour immediately following traumatic injury in which medical treatment for preventing irreversible internal damage and optimizing the chance of survival is more effective. Unfortunately, in India and my experience, only in a trauma center, I think in UP, I think 20-30% of the patients are only able to reach hospital within 2 hours. Otherwise, they may switch to the local hospital or somewhere, and they are getting referred after that. Because of that, it is very difficult for the surgeons, trauma surgeons, and us to manage them. So McDonald Trunke has summarized the golden hour by 3R rule. McDonald Trunke is a famous trauma surgeon and wrote many trauma books. So the right patient to the right place at the right time. This is a basic key of the golden hour. So the trimodal distribution of the death. So this is the historic trauma trimodal distribution of the death, which shows that 80% of the deaths occur in the first hour of the injury. So, and 20% by hours to weeks. Whereas the new biomodel trauma death distribution shows 90% of the injuries death occur in first 4 hours. So it is this hour is very crucial. So if the patient reach in this time to the trauma center, it is likelihood of survival of the patient is more. Essential trauma services need of the injured patient. So life-threatening injuries are appropriately treated promptly and in accordance with the appropriate priorities so as to maximize the likelihood of survival. Potentially disabling injuries are treated appropriately so that to minimize functional impairment, and pain and psychological suffering are minimized. So under these 3 broad headings, essential trauma services, there are some specific medical goals. First is obstructed airway are open and maintained before the hypoxia leads to death or permanent disability. Impaired breathing is supported until the injured patient to breathe adequately. Pneumothorax and hemothorax, tension pneumothorax are promptly recognized and relieved. Bleeding, external or internal, is promptly stopped. Shock is recognized and treated with intravenous fluid replacement before irreversible consequences occur. The consequences of traumatic brain injury are lessened by timely decompression of the space occupying lesions and by prevention of the secondary brain injury. Intestinal and other abdominal injuries are promptly recognized and repaired. Potentially disabling extremity injuries are corrected. Potentially unstable spinal cord injuries are recognized and managed appropriately, including the immobilization. So mantra of managing trauma is A, B, C, D, E. It is already discussed in earlier session also. So we have to go in this way. So this is the global mandate of World Health Assembly. So the 6th World Health Assembly, the agenda was the health system, emergency care system. The 8th World Assembly, the agenda was strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. In 22 January 2011, strengthening national health emergency and disaster management capabilities and resilience of the health system. And in 2019, the emergency care system of the universal health coverage, ensuring timely care of the injured. So United Nations and World Health Assembly has called this strengthening for the trauma and emergency services. So the timely emergency care saves lives. So this slide shows that the essential function of an emergency care system, from the care at the scene to transport and care of the facility, every country including arts, achieves these functions in some way, affordable, sustainable improvement can be made building on this space. So from the scene to the transport facility, it is the important role. So the continuum of the care of the injured. So bystanders, simple action can save lives. Training of drivers and police is highly impact. But unfortunately, I have seen so many people used to bring the patient very late. Bystanders are not that much aware how to manage, and moreover, they are afraid of the legal liabilities. Then the pre-hospital scene and transport care, trained and certified first responder to improve the outcome, simple low-cost dispatch system to ensure the timely care. Hospital care is also very important. If we talk about a country like in India and especially Uttar Pradesh, hospital ambulance used to be available, but the emergency medical technicians are not intervening much with the patient. The work is only to shift the patient from the scene to the hospital. So initial management, pre-hospital management, if they do, we would be able to save the patient to some extent. Then hospital systemic care of the every injured person in the emergency unit, timely operative and the critical care. Rehabilitation, maximize the impact of the emergency and surgical care, getting people back to the daily life. So injury care is a good investment and it helps to avoid the high cost of early death, complication, prolonged recovery, preventable disability, lost wages and productivity of the society. So here's a Mr. John who fell from the tree when he was 8-year-old and trying to get mangoes. There was no one at the local health facility and able to treat his fracture with a simple procedure. Now he is 11-year-old and has a difficulty in walking and playing, and he will face lifelong difficulties working in the caring of his family and affecting the quality of life. Now, integration of the system of trauma management. So pre-hospital triage in a location with a well-organized EMS within several alternative hospital at varying level of the trauma capabilities is very important, as focused by Suresh Sharma sir also. So EMS, emergency medical services, are very important, and emergency medical technician, unfortunately, government is not looking at them. They are not getting any good scope in the government sector as an emergency medical technician. So it is very important to implement, especially in India. This implies that more severely injured patient would be taken to the nearest suitable hospital, not necessarily the geographically nearest hospital. This is happening so many means here we face such problem because majority of the patients that we attend in BHU trauma center are coming from Bihar. So before coming to the trauma center, specialized trauma center, they go to the local hospital and they are not getting proper emergency management, or in the like in a very deteriorated condition, like especially if I talk about the head injuries, they come in a very compromised status. We are not able to save the patient or resuscitate the patient that time. So this is based on the training of a EMS personnel in a various triage criteria, including the use of a scoring algorithm such as trauma scoring system and pre-hospital index. There are many trauma scoring systems developed now. So it is dependent upon the individual hospital which trauma system scoring they are following. It also implies a detailed pre-existing arrangement with the EMS and the hospital in a given city or area. As per my experience, there is apart from that patient is arriving, there is no initial information like vitals or nothing is shared from the EMS person to hospital. Now, designation of the trauma center. Designation implies that the political jurisdiction has made a selection among the various alternative hospitals as to which one should be expected to meet a varying criteria of trauma capabilities, ranging from a small rural hospital up to the large urban trauma center. Now, referrals and inter-hospital transfer. It is also very important. This includes transfer criteria specifying which type of injuries, level of severely injured should be transferred from a smaller hospital to the larger hospital. The problem, what I think, that majority of the smaller hospital where the patient find itself.
Sorry to interrupt you, Dr. Rajni. Please.
Sir. Okay.
Please, little bit faster.
Okay. So the goals of such transfer agreements and protocol are to decrease the time needed to carry out the transfer critically injured patient by assuring the necessary communication between medical care provider and agent. So communication, I said, it has a very important role, especially the EMS to the hospital and the further referral center. So pre-existing transfer agreement can help to streamline such processes. So transport, there is a course of several barriers in the transfer of injured patient of highly levels of the healthcare system. So economic barrier is one of the barrier, and one of the thing that they prefer to go to the near to their places where the family can stay in a local area, and this affects the patient, especially in trauma. Then setting of the facility. So as I've already discussed about this, then data of the injury surveillance is also very much important. Finally, an effort to improve the system of trauma management need to include the provision of ongoing evaluation. So rehabilitation also makes emergency care more cost effective. So post-operative rehabilitation decreases the length and stay cost by $1,600 per patient. So SDGs, SDG goals. So by 2020, half of the number of the global death and injuries from the road traffic accident, post-crash emergency care and rehabilitation could avert around 40% of these deaths. Also, timely emergency care assist is a critical for the effective universal health coverage. So impact of emergency care, over half of the death and third of the disability in low and middle income countries are from the condition treatable emergency care. So where we are now, so this is the comparison with the UK. So here it is projected that by 2020 we'll be having more than 5 lakh deaths globally from the trauma, and by 2025 it is more than 5 lakh deaths due to the trauma. This is very alarming sign. So what do we know? So injuries are the leading cause of death and disability. Injury deaths are much higher in low and middle income countries. Emergency care is effective at a limiting impact of the injuries and improving the outcome. Emergency care is a great integrated investment, improving the outcome of a range of health conditions. The UN and World Health Assembly has called the urgent action for strengthening the emergency care, and well-organized emergency care system can help to achieve many SDGs. So what next? So train frontline provider in a basic emergency care, as already discussed very detailed about with Vice Suresh Sharma sir. Conduct a national assessment with WHO emergency care system assessment. Implement the WHO trauma care checklist is one of the standard checklists I feel, and the WHO ICRC integrated triage tool. Conduct facility assessment, level assessment on emergency and trauma care capacity. Collect the use of data, facility improvement initiative via the WHO International Registry for the trauma and the emergency care. Thank you very much.
Thank you, Dr. Rajni. Thank you very much. You can stop the screen sharing now. And thank you very much for giving us a global as well as the regional perspective about how the trauma patients are being managed as of now, and what are the possibilities where we can improve. The house is open now, and we can take questions from the panelists or any comments to make. Please.
Sir, I just would like to add that all three presentations were wonderful by our distinguished speakers. Like in first presentation, as said by Dr. Suresh, like we need to upskill our existing nurses related to the trauma nursing. So, and we need to provide them license for the trauma nursing, like specialized care, what they're providing. So we need to give a license to them. So this was a brilliant idea. And I would like to congratulate sir for starting the MSc nursing in trauma nursing in AIIMS Jodhpur and AIIMS Rishikesh. And in second presentation by Dr. Saraswati, ma'am has told about, she has enlightened, she was having a very enlightening session. She has told about how to manage the mass casualty and how we need to train our responders, the person who are at their quick reaction team. We need to train those responders. So it was beautifully explained by Saraswati ma'am. And in third presentation by Dr. Rajni, ma'am has highlighted the need of golden hour. That is, I think, very, very important to know. Like telling about the 3 hours, the right patient, the right place, the right time. So in India, there is a lack of public awareness. So usually the patients are there at road, we don't know when to shift the patient to the hospital. So that needs to be told to the normal general public also. Public awareness is required. So this was a brilliant presentation by all our three speakers. Thank you.
Thank you, Dr. Sima. And I think I cannot agree more than that, what we have just mentioned. So thank you once again to all the respected faculties for taking your time out of your busy schedules and making us more knowledgeable about what we might have lacking. And I request all of you to please join us in Hall A for the beautiful inauguration session. And after that, we will be joining here back at 4 o'clock for the next session. And I request again all the speakers and chairperson of that session to join us 10-15 minutes back so that we can have a chat. Thank you very much. Have a good day.
Thank you.
So thank you all, and I have got the feedback from my event managers that a lot of people, more than around 700 people are there right now who are attending the inaugural Congress. Thank you so much for joining here. I thank our guest of honor, Professor Parminder Lal, who had been busy with another conference, but he spared his valuable time and joined us and gave his pulse of wisdom to our postgraduates who want to take up a specialty like trauma surgery and acute care as their future prospect and future career. Words fall short for our orator, Professor Dr. Matthew Varghese.
Very good evening. Good evening to all esteemed faculties. We are a little bit late because of delay in the inaugural session, but now we are back. So we are good to go with the session. And tech team. Hello. Anyone from tech team? Ma'am, Saraswati ma'am?
We can hear you.
Yeah, so you are the lone chairperson. Sorry to say, I think Professor Suresh is supposed to be joined, but probably he's not in the panel as of now. So okay. I think we know that you can take care of full army, then you can very well take care of the session. So all burden on your soldier, ma'am.
Yeah.
So we are good. Tech team?
Yeah.
Hello.
Yes, please.
Anyone from tech team?
Yes, sir.
So we are good to go?
Yes, sir.
So on the count of 5? Or we are live?
We are going live in 5, 4, 3, 2, 1. We are live.
So good evening once again to the next session of the trauma nursing session after such a elaborative and knowledgeable inauguration session. And in this session we have as chairperson Professor Suresh Sharma. He is the Principal College of Nursing, AIIMS Jodhpur. Unfortunately, due to his official commitment, he will not be able to join us. But we have one of the more senior faculty of nursing in our country, I would say, Brigadier Saraswati ma'am. Ma'am, very good evening again and welcome you for the next session as a chairperson kindly take up and run the session. Speaker slide, please.
Dr. Dinesh, whether I should begin or Madam?
Okay. Thank you, sir. Thank you very much. I'm sorry to say that I thought that you will not be joining, but thank you very much, sir. Thank you for your.
I was right there actually. I was in inauguration in
Okay.
Yeah,
thank you. So Dr. Suresh has also joined. So I think we should go as per the flow we decided, and I request Professor Suresh to introduce our first speaker, please, sir.
Sure. We are privileged to have the first speaker, Dr. Seema Sachdeva. Dr. Seema Sachdeva is faculty at College of Nursing, AIIMS, Delhi. She is alumni from PGI Chandigarh and a faculty at ATCN. She is going to talk today about trauma management in special population. Now, stage is for you, Dr. Seema.
Thank you so much, sir. So can you see my screen?
Yes, we can see.
Yes, ma'am, we can see. Kindly do it on the presentation mode.
So
I think you are presenting from the Google. So you can continue, ma'am. Continue with the same.
Okay. So before I start, I would like to say thanks to the organizing team, to my chairperson. So the presentation, I want to make it on slideshow. Okay. So this is about. Okay. So this is a trauma management in special population. Special population means the vulnerable age group, the one needs a more attention. So we need to understand the mechanism of injury, the special attention to this specialized group. Like the special population, it comes the pediatric population, the geriatric population, and the pregnant ladies. The main objectives of trauma management is rapid identification, prioritization of traumatic injuries to pediatric population, geriatric population, and pregnant patients. First, we need to identify the trauma. We have to do the initial assessment, and we have to prioritize, and we have to see whether A, B, C, D is compromised, and accordingly we have to provide the care to the patient. To review the assessment findings and discuss the treatment strategies, to manage the traumatic injuries to most challenging patients by delivering of most effective prioritized trauma care. Now coming to trauma in pediatric population, trauma is the most common cause of morbidity and mortality in pediatric population. The children, they have their unique anatomy and physiology, which differs from an adult population, and it has to be considered at a time of pediatric trauma. We need to understand the mechanism of injury based upon their anatomical and physiological changes. Motor vehicle associated injuries and falls are the most common causes of death from the injuries in children of all ages. And the main goal is to prevent the death that occur from minutes to hours after injury, as it was told by the Rajni ma'am in the previous slides related to the golden hours. So coming to the basic anatomy and physiological changes in terms of airway, breathing, circulation, disability, and environmental control. So airway is not alone, it always go with the C-spine stabilization. So the differences, what are the physical differences in terms of airway in case of pediatric population? So because of the small size of the child, they have a larger tongue. So if there is a larger tongue, there are chances that there can be an airway obstruction. So when the child is not conscious or there is a threatened airway, there are chances that tongue fall can be there and it can lead to the airway obstruction. So we need to know if there is child trauma in the pediatric population, we need to know that this child, if the child is unconscious, this child can have risk of airway obstruction. So we have to think of maintaining a patent airway in a very early stage. The children usually have anterior lying larynx. So which make the larynx, which make the visualization of vocal cords quite difficult at a time of intubation. That's why we need a, we usually, there is a need of using a straight blade for endotracheal intubation. The children, they have a shorter and narrow airway. The size of the trachea is usually 5 centimeter when the child is, when the infant is born, when there is a newborn, and the size increases to 8 centimeter when the child is around 18 months. So if the trachea is small, there are chances that there can be a right main stem bronchial intubation. So that can lead to ineffective oxygenation. The child usually have much larger occiput. There is a, that like head size is quite large, the occiput is quite large, which lead to flexion of the neck muscles. So which can cause a airway obstruction. And the child usually have flexible spinal ligaments. Usually at C2 and C2 to C4, the cervical ligament, C2 to C4, there can be pseudo-luxation. Even if the child is having the fracture of the cervical ligament, cervical vertebrae, there are chances that in spinal X-ray, it may not show that fracture. So there can be a chances of spinal cord injury without radiographic abnormalities. So the definitive diagnosis to pick up that fracture is through CT scan. Through X-ray, we may just come to know the child is not having the cervical spine fracture, but actually it is there because C2 to C4 any time it can be pseudo-luxated. So it may not be visible in the X-ray. So we need to pick up with the definitive diagnosis, that is a CT scan. As you can see in this picture, to maintain a neutral position, to maintain a patent airway, we need to give a neutral position because the child is having a bigger occiput. So there are chances that neck muscles can be flexed. So we have to avoid the sniffing position and we have to give a neutral position. So to maintain a neutral position, we have to put a 1-inch thick pad under the entire torso. Starting from the shoulder, we have to cover the complete torso to maintain a neutral position so that mid-face is parallel to the spinal board and the airway becomes patent. Now the differences in terms of breathing. The children, they usually have the small tidal volume and they have a very weak intercostal. The intercostal muscles are not fully developed. And these children, they usually have soft, pliable and soft wall of chest. It's that sternum and the rib are quite cartilaginous. So there are chances that with the impact, they can have a pulmonary contusion, but rib fracture, it may not be there. In X-rays or in a fast, in X-ray, we may not see the rib fracture, but actually there is a pulmonary contusion just because the ribs are quite cartilaginous and it's quite flexible. The chest wall is quite flexible. It's very soft. And in case if there is a rib fracture, that means it is a very, like it indicates a significant force. The high trauma has been there. So we have to think of that if rib fracture is there, that means significant injury has happened to the chest. And the tension pneumothorax among children, it is poorly tolerated. Usually they decompensate very early. Once the compensatory mechanism is off, they decompensate very early. So we have to think of that these children can have, based upon the sign and symptom, we have to think of tension pneumothorax and accordingly we have to do the management. Respiratory rate also differs in a different age group. Like when the child is like from 0 to 2 years, the respiratory rate is 40 to 60. As the age increases, the respiratory rate, it comes down. Like by the 6 to 12 years, it comes to less than 30. In terms of circulation, the physical differences among children are, they have a compact abdominal organs. The abdominal wall is quite weak and it is quite bulging. So there are, because all the abdominal organs are lying close to each other. So with a small impact, there are chances that they can have multiple organ injuries. The liver, spleen, it is all lying together. So there are chances that with a small impact, they can have injury to the multiple abdominal organs. And the children usually have soft, thinner muscular wall, and there can be chances of internal organ injuries. And they have age-specific vital signs. And with that, there can be chances of sudden deterioration when the physiological reserves are over. When the compensatory mechanism is over, there are chances that they can have a sudden deterioration. And they have a smaller blood volume. Like in infant, the blood volume is around 80 ml per kg. And in children, the blood volume is around 70 ml per kg. So even a small amount of blood loss can lead to the shock in terms of children. They can, by the time we come to know they are in shock, they can already be there into the stage 3 or stage 4 shock because of smaller blood volume. the children, if they have a hypotension, usually hypotension, it happens late. Earlier, there is a tachycardia, and in the stage 3 or later stage, they have a hypotension. If it is a hypotension, then there is a time when there is a decompensated shock, like the compensatory mechanism has gone off and now the decompensation is started. So child deteriorate very early if the child is having the hypotension. Disability, if this ABC was over, now coming to the disability, D for disability, the physical differences is the children usually have a much larger head and the weak neck muscles and the ligament. So there is a weak neck muscles which can cause the flexion of the, and it makes a airway obstruction, chances of airway obstructions are there. Moreover, the children in terms of newborn, they may have a open fontanelles and the mobile cranial sutures. So there are chances that with that injury, they can have a more diffuse brain injuries. And they have a weak cervical ligaments, which and there can be chances of spinal cord injury without radiographic abnormalities, because C2 to C4 it's pseudo-luxated and we can't see it in when the child goes for a, when we go for a X-ray of spine. And pediatric GCS is also differs from the adult, like in terms of verbal only, the we can see, like in case of 5, the child smiles and oriented to sounds. If it is 4, the child will cry, but it is consolable. And if it is 3, the child is it's inconsistently inconsolable and it moans. And if 2, it's inconsolable and child is agitated. And if it is 1, no response. Rest other eyes and motor responses same in terms of pediatric GCS. Environment and exposure. This is the E part. In E part, coming to the thermoregulation, as compared to the body mass or body volume, the body surface area is quite big. So if there's a large body surface area, the heat loss will be there. So among children, there are chances that there is a heat loss quite early. So moreover, they have a less insulation by subcutaneous fat. They have a thin skin, less subcutaneous fat, so thermoregulation is also less, so they will lose the heat. There are chances that they can go into the hypothermia, and with the hypothermia there are other complications which can develop, that is acidosis, or there can be coagulation problem. So these all 3 things can be there but develop with the hypothermia. So we need to take care of while managing the trauma children, we need to take care of maintaining the temperature also. The primary survey goal is we have to identify whether we have to maintain a secure and protect the airway by giving a neutral position to the child. And in terms of breathing, apnea, if the child is not breathing, we have to give a positive pressure ventilation. We have to think, we need to have a high index of suspicion, and we have to think that this child is having if the GCS is less than 8 or threatened airway, we have to think of early intubation in terms of children. Or if the child is having hypoxia, the child is having respiratory distress, think of giving the supplemental oxygen to the child. If the child is having the symptoms related to the tension pneumothorax, like respiratory distress or no air entry, tracheal deviation, or the jugular venal distension, then we have to think of needle decompression, followed by the chest tube at 5th intercostal space. And
again, sorry to disturb you, Dr. Seema, if we can be a little bit more swift.
Okay, sir.
Please.
Okay. So the special intervention which are required in terms of pediatric population is we need to take a cervical collar off while at the time of intubation. Obviously, with the airway, we need to apply the inline mobilization, like putting the cervical collar, but at the time of intubation, to maintain the cervical spine in position, we have to give the inline mobilization and need an aggressive airway management. And we have to think of putting an uncuffed ET tube. If the child is having the threatened airway, we have to think of aggressive airway management. Don't think when the child is going to have apnea, then we will think of intubation. And continuous vital assessment, because the child have a high physiological reserves, and when the compensatory mechanism is off, they will decompensate very early. And to check the tube placement, we usually go for 5-point auscultation and ETCO2 monitor or waveform capnography. Tachycardia is the first sign of shock which we have to think of. If the child is having tachycardia, just think of the child may have the, if the child is not bleeding externally, he may have the internal bleeding. So we have to think of that if the tachycardia is there. So BP has to be maintained with the blood loss. BP may be maintained with the blood loss of up to 45%. So hypotension is a late indicator. Once the tachycardia is there, altered mental status is there, we have to think the child is going into the shock. Don't rely on the BP because BP is a late indicator. And the danger sign is hypotension is the sign of decompensated shock. Once the child is going into the hypotension, he may go into the bradycardia. Hypotension plus bradycardia, the child can go into the cardiac arrest. So that is a very late stage. So we have to think of it very early and think of early neurosurgical consultation and reduce the intracranial pressure by giving the mannitol. While giving the fluid resuscitation, we have to think of 3 boluses with the rate of 20 ml per kg. And if the percutaneous access is not possible, just we have to plan for the intraosseous needle for the infusion. And the main sites are for intraosseous is distal femur and proximal tibia. And maintain the temperature using thermal blankets, heater, warm fluids, and blood products. This is a Broslow pediatric resuscitation tape. This is very, very important, which we usually use into the trauma resuscitation among the pediatric population. This is a length-based resuscitation tape. So based upon the length, everything is mentioned on this tape, like what resuscitation equipment has to be used, what is the size of those resuscitation equipment, what drugs to be used for the intubation, what should be the doses of that drugs, that everything is mentioned on this resuscitation tape. And this is length-based resuscitation tape. So how we'll come to know the child is responding to the resuscitation? Obviously, there will be, if earlier it was tachycardia, the heart rate is coming back to the normal, improvement into the mental status, return of peripheral pulses. If earlier there was no peripheral pulses or very weak and thready, now there is a good volume, peripheral pulses are coming back. Urine output is 1 to 2 ml per kg per hour, and the skin is quite warm. The extremities, its normal skin color is there. So the child pediatric trauma, it is preventable. We have to do a over triage is far better than the under triage, because if we do the under triage, the child airway breathing compromise. If we are putting the child into the yellow color code, the one whose airway breathing and circulation is compromised, so we may lose that child. So better to do a over triage, and triage is a continuous process. We have to reassess the child based upon the condition of the patient. And continuous assessment and management is required. Never hesitate to admit for observation.
Dr. Sima, please, little early, because we are running short of time.
Okay, sir, I'll try. Now I'll just go through the main
yes, please,
key
please,
points only.
please,
Trauma into the geriatric population. So in geriatric population, we have to think of like whatever the condition which is there into the normal adult person. So we have to have an extra index of suspicion, because they have a decreased physiological reserve. They may have a extra comorbidities in which we have to think of the mechanism of injury among those geriatric population. So fall is the most common cause of injury among the geriatric population. Among airway, they have the decreased reserves, which they may require the early intubation. The dentures, the cervical arthritis, it may cause the difficult intubation. So we have to think of difficult intubation for the geriatric population. We need to have adjuncts. While in the intubation trolley itself, we need to have adjuncts. For breathing, we need to think of careful oxygenation, because if we give a high oxygenation, they may go, already they are either COPD patients, they may have a carbon dioxide retention. So we have to think of careful oxygenation. They may have decreased lung elasticity, and the minor chest injuries, it may have a significant respiratory compromise. For circulation, there may be a decreased cardiovascular function and reserve, because of they may have the cardiovascular diseases. They may have a lower heart rate because they may be on beta blockers. They may have a low stroke volume. So we need to maintain the proper cardiac output by careful administration of the IV fluids. And systolic BP, if it is less than 100 mmHg, which may be normal for an adult person, but for a geriatric population, the one who are already hypertensive, if systolic BP less than 100, it may indicate the sign of shock. The special intervention which is required for geriatric population, we need to do a triage and retriage. As I have told, triage is a continuous process, and repeated primary survey and management. Cautious administration of supplemental oxygenation. We cannot give them very high flow of oxygen, because they may have a COPD. They may lose a drive to take oxygenation to take a next drive. So careful administration of oxygen is required. Maintain saturation more than 90%. Anticipate difficult intubation. We need to have adjuncts for the airway, like iGel or the LMA. It should be there on the intubation trolley. ABG monitoring is required. Think of early intubation if the chest trauma is there. Risk of pulmonary edema. So we have to avoid the liberal fluid administration and careful review of medication. Always take a history what medication patient is taking, or what patient is having any allergy to any specific treatment or any specific drugs, and avoid the hypothermia. So the main summary is comprehensive geriatric assessment, prevention and management of geriatric syndromes, maintain functional preservation, and involve the family in the care of the patient. Now the last one is trauma in pregnancy. So it is
ma'am, please conclude it in short time.
Okay. Trauma in pregnancy, here we have to think of special attention is required because 2 lives are involved. So the basic focus is to maintain proper oxygenation, ABCD of mother. If ABCD of mother is maintained, fetal oxygenation is maintained. So we have to think first, we have to think of mother resuscitation. So trauma is the most leading cause of non-obstetrical deaths in expectant mothers. So the main physiological changes, plasma volume increases, cardiac output increases, and blood pressure declined by 20% in second trimester. The main challenges in resuscitation is oxygen consumption is quite high because of increased demand. They have an increased oxygen demand in the last trimester usually. Hypovolemia can go undetected because already the plasma volume is quite high. And intubating a pregnant woman is 5 to 8 times more difficult. So that's why we have to think of difficult airway intubation. And pelvic trauma and uterine injury may lead to the appreciable hemorrhage. The main complication can be placenta abruptia, uterine rupture, and feto-maternal hemorrhage. So the key points in management, always go for mother resuscitation, that will have a good fetal outcome. And while at the time of CPR, go for the left lateral uterine displacement, and manual uterine displacement may allow for more effective chest compression in CPR. Go for nasogastric decompression and maintain maternal oxygenation more than 95%. And they need to give a anti-D immunoglobulin within 72 hours of trauma. And Doppler ultrasound is required to see the fetal oxygenation and circulation. So take home messages, over triage rather than under triage is always better. Always go for primary survey, adjuncts, and then secondary survey. Understand the specific differences in anatomy and physiology of this special population, and timely consultation and referral for good outcome. So these are my references.
Thank you very much, Dr. Sima, for a elaborative task. And before wasting much time, shall we proceed with the next speaker? Saraswati ma'am, I would request you to introduce the next speaker, please.
Yes. Thank you.
And I request all the speakers to please take consideration of the time while presenting. Thank you very much.
Thank you very much. Wound care nurses are also called as bandaging angels, you see. They bring their skills and techniques together to heal patients physically and mentally. So here I welcome Ms. Vanilla, a postgraduate and wound care nurse from JP and Apex Trauma Center, New Delhi. Welcome, Vanilla.
Thank you, ma'am, for your warm welcome. So in this session, I'm going to talk about how wound care nurses helps in post-traumatic wound management in a trauma center. So the wound surveillance program started at JPNHSC as a new concept in January 2011. This program started with the following objectives, like to enhance consistency and continuity of care, to practice standardized wound care pathways and protocols, provide objective and accurate data for documentation as well as outcome measurement, to follow up of patient from admission till rehabilitation, to also participate actively in research, in service education and orientation programs. So, and also to involving prevention education and screening of high-risk patients. So who is a wound care nurse? The nurse who is assessed for wound care practices. Wound care nurse also teaches and train in preventive care. They are a link between patient, surgeon, and other healthcare professionals. They play a crucial teaching role in educating patients, family, caregiver regarding the home-based care. Their job is different from bedside nursing staff, as they are involved in vertical management of patient from admission to discharge. So their job description is to ensure standard wound dressing practices, to ensure proper selection of dressing material, to give special attention to patients with complex traumatic wounds. They also ensure proper pain management. They ensure early ambulation of patients. They assess and minimize risk factors for pressure ulcers. They also give digital teaching plans and health education. They keep the record both manual and computerized. So we have our own roles and responsibilities. So in which first we'll see about in inpatient departments. So wound care nurses are posted in all inpatient area of trauma center, like all the wards and ICUs. So they will assess each patient admitted in the wards or ICUs, and they ensure proper pressure ulcer prevention and proper usage of appropriate dressing for the various wounds. So first, the wound care nurse will take over from the night duty staff about how many patients are there in the ICU or ward to know about the general condition of the patient. After taking over from the night duty staff, the wound care nurse will prepare the dressing trolley. She will arrange all the necessary items, the dressing items which is needed in the dressings in the dressing trolley. So after preparing the dressing trolley, the wound care nurse will do head-to-toe assessment of each and every patient admitted in the ward or ICU. So while doing head-to-toe assessment, the nurse will check about all the pressure points for any redness or skin peeling. She also checked for any abrasions or any missed injuries. So apart from that, in traumatic patients, the medical device related pressure injuries are more common. So the wound care nurse will assess all the medical devices which is applied to the patient for their proper padding as well as frequent change of position of saturation probe and BP cuff. Here I shared some of pictures which is related to pressure injury related to medical devices. And along with the head-to-toe assessment, the wound care nurse will do Braden scoring of each and every patient who is admitted in the ward or ICU. So the Braden score is a tool which is used to identify the high-risk patient who was prone to get pressure injuries. So this scale has a maximum score of 23 and minimum score of 6. So the patient who is having more than 18 score are considered no risk. The patient with a low score of 15 to 16 are considered mild risk. The patient with a score of 12 to 14 are considered moderate risk. And the patient with a score of less than 12 are considered high risk. Once the wound care nurse identified the high risk patient, then she will implement the pressure ulcer prevention protocol, which may include applying air mattress, educating the caregivers regarding the moist or wet linen has to be changed immediately, and also will educate the caregivers that the position of the patient has to be changed every second hourly, and skin care has to be given with the moisturizer, and also to give a protein rich diet, and also advised to avoid wrinkles on the bed as well as avoid friction shear pose while changing the bed sheets. So these are all may help to prevent the pressure ulcer in the high risk patients. So after doing patient assessment, the wound care nurse will actively participate in the faculty rounds along with the residents, physiotherapists, and assigned staff. So during this clinical rounds, the team will discuss about the wound condition of each patient, and they will decide what kind of dressing to be done for that particular patient. So after the rounds, the wound care nurse will assist the residents in doing dressing. So while assisting the dressing, the wound care nurse must ensure the following. So she should ensure the patient privacy is maintained. She also ensures that the proper pain giver or analysis is given before the dressing is started for each and every patient, because pain is also a important factor in wound management. So she ensures proper pain management before the dressing, at the time of dressing. So she also ensures the residents is following the aseptic technique throughout the dressing. And also she ensures that the particular dressing which is decided during the faculty rounds is done for that particular patient. So she also help the residents in selecting proper dressing material. And also they give psychological support during the dressing to the patients. So here are different kinds of dressing we are using in our trauma. Hydrochloride dressing can be used in superficial wounds like abrasions. Semi-permeable adhesive film dressing can be used in post-operative wound dressings. Low adherent dressings may be used over the grafts or flaps. Foam dressings can be used in mild to moderate exudating wounds. Collagen dressings can be used in a cavity type wound, and AG dressing, that is silver dressings, can be used in infected wounds. So during the dressing, if the wound looks bad or like if wound is infected, the wound care nurse will collect the wound swab and send it to the microbiology lab. So the wound care nurse is also wound photography while assisting the dressing. For doing wound photography, we have to remove all the dressings and we have to remove as much as necrotic tissue as left from the wound. Then we have to clean the wound thoroughly with a saline. Then we have to hold the camera parallel to the plane of the wound with an optimal distance of 30 centimeters. So after wound photography, the wound care nurses also keep serial photography of each and every patient's wound, which will help us in a outcome measurement in the future. We also do wound measurements during the dressings. So by using wound measurement scale, it is also helps us in outcome measurement. So after doing dressings and all, assisting dressing and all, along with the physiotherapist, the wound care nurse help and encourage the patients to do respiratory exercises, active and passive limb exercises, and also wound care nurses will do yearly ambulation of patients along with the physiotherapist. So yearly ambulation is important in traumatic patients, which will help us in preventing pressure ulcer as well as it improves the wound healing as early as possible. She also coordinates with other departments like dietitian. If the special dietary requirements of a traumatic patient, she will communicate that to the dietitian. If the patient is needed any splints or TENS therapy or CPM, that she will communicate to the physiotherapist, and the traumatic wound management plans to the assigned staff. If the patient is having polytrauma, then the wound care nurse will coordinate with other department doctors like orthopedics, neurosurgery, and microbiology. So after assisting the dressing, the wound care nurse also document the wound description of each patient in the computerized patient record system. So while documenting, she ensured or document about the tissue. How was the tissue? It was healthy or it is sloughy or it is granulating, and whether there is infection or inflammation or there is any excess moisture or whether the moisture is adequate, about the edges of the wound, whether it is regular or is there any undermining or tunneling, and also about the exudate, whether it is mild, moderate or heavy. So at the time of discharge, the wound care nurses also counsel the patients about health teaching for home-based care includes personal hygiene, tracheostomy care, stoma care. So most of our trauma patients are discharged with stomas, tracheostomies. So the wound care nurse will explain about how to care of tracheostomy or stoma at home, as well as with the wounds also we discharge the patient with the wounds. So the wound care nurses will teach the patient as well as caregiver about the home care. So in outpatient department, the wound care nurse attend every OPD of all the department to follow up the patients with the chronic wounds. So in the OPDs, the wound care will maintain the registers. They do photography. They collect wound culture swabs. They also assist in the dressing. They give health education as per the patient need. They receive feedback from the patient, and they also explain about the next visit, when to come, where to come. So apart from that, we have a role in advanced wound management technique. First one is negative pressure wound therapy. So negative pressure wound therapy is used in highly exudating wounds to remove the exudate as well as to get granulation tissue before the wound closure. So the wound care nurse will assist both in the application and removal of negative pressure wound therapy. Apart from that, she will maintain position of the patient to maintain the seal. And she also do pain assessment and dressing changes. She check drains whether do not cause any pressure injuries to the patient. And also she do periodic observation for soakages. She also assesses for any local changes, that is color, temperature, or pain or swelling. She also checks whether the healthy skin is not damaged by the contact with the foam, gauze, or drain. She closely monitors the alarms. So if the therapy is off, she will make sure that it should be on. If therapy is off for more time, it can deteriorate the wound condition. If the canister is full, it has to be replaced immediately. Also, she checks air leak and do the proper sealing of air leak. Hyperbaric oxygen therapy. So it's a bloodless wound management method in which in trauma we have monoplace oxygen chamber unit. So in this HVOT unit is assisted by a wound care nurse. They do proper monitoring of all the patients receiving HVOT. They do serial photography and documentation of the same. So before starting the therapy, the wound care nurse ensures the following, like consent of patient, they are wearing cotton clothes at the time of therapy, removing artificial dentures, contact lenses, hearing aid, and they advise the patient do not come empty stomach for hyperbaric therapy. They also advise do not apply oil or cream on the body or hair. And also advise do not carry any electronic devices, valuables, or while coming for the therapy. If the patient is having tracheostomy or airway, that made to be clean, dry before the therapy. And all the wounds must have only dry dressing at the time of therapy. So dry dressing will help more absorption at the local site. And also for ENT clearance. So in hyperbaric oxygen therapy, we are giving 100% oxygen to the patient at a particular atmospheric pressure. So that pressure may cause eardrum damage. So before the therapy, the wound care nurse ensures that the patient is having ENT clearance. And also they administer nasal drops to both the nostrils of the patient immediately before the therapy is started. And they advise the patient to do repeat swallowing or Valsalva maneuver at the time of during compression and decompression phase. And also they advise the patient to do not report for HVOT if the patient is suffering from fever or upper respiratory tract infection or high sugars. Amniotic membrane application is a new ongoing project in our trauma. So in this, the amniotic membrane is applied to the wound bed for preparing the wound bed before the grafting. So it helps in reducing edema, infection, as well as it reduces the pain at the wound site. So in this, the wound care nurses arranges amniotic membrane from the stem cell department. They also ensure proper secondary dressing and proper secondary dressing is changed every alternative days. So apart from the routine work, the wound care nurses also have special assignments during holy and mass casualties. So during these times, the wound care nurses are posted in a shift duty. In each shift, they are posted in a minor OT. So in minor OT, they do thorough examination of all the wounds for any foreign material, and they also ensure the thorough wash of the wound before it gets closure. So they also
please be a little bit quick.
Okay, sir. So they also ensures correct adequate pain management before all the minor OT procedures. They also ensure the aseptic technique, and they provide health education to each and every single patient attending the minor OT, when follow-up date and time, wound washing. But wound washing is very important because the patient is having trauma stigma that the wound cannot be washed once it is sutured. So if it is washed with soap and water, it may get infection. So the wound care nurse will make sure that the wound should be washed with soap and water after 12 hours of suturing, and also educate about proper use of antibiotics and maintain proper nutrition. So apart from that, amputation clinic. So amputation clinic also they attend. So in amputation clinic, they do wound inspection and they will assist in dressing. In amputation clinic, they reinforces the patients to do some bandaging with the tub bandage to make a shape of the stump, and also to do massages to the residual limb. So it can help in reduce edema, phantom limb pain, stiffness, stress, and anxiety. They also help the amputees to get prosthesis and also They help us to how to use that prosthesis properly. And they also help the amputees in all the 5 stages of rehabilitation, starting from healing and visiting prosthetists, choosing an artificial limb, learning how to use artificial limb life as a new amputee. So DACIN solution preparation, it is nothing but it is a diluted sodium hypochlorite solution, 0.5%. It is actually a alkaline based solution in which we maintain the pH of 9 to 10. So during this pandemic period, we faced a new challenge, mucormycosis. At that time, we wound care nurses prepared DACIN solution for washing the wounds, and it found to be more effective. Here I share the picture of wound mucormycosis patient, and it is healed after washing with the solution. So after involving the wound care nurses in traumatic wound management, the wounds, they help the patients in wound healing, as well as there is a significant reduction in the rate of hospitalized pressure ulcer in comparison with the high-risk patient. The outcome of pressure ulcer also has improved because the maximum of the pressure ulcer or identified in the stage 1 itself. So they also, the wound care nurses also try to heal at the stage 1 or stage 2 itself. So though the number of hospitalized pressure ulcer has decreased, the number of follow-up patients coming up with the pressure ulcer has increased. So the wound care nurses developed a home care manual, both in the English and Hindi version. So it helps the caregivers for the better understanding. So we distribute this manual to the patient and relatives at the time of discharge. So after distributing this manual, the follow-up of patient coming with pressure ulcer also decreased. So here are the some papers and posters we wound care nurses presented at various national and international conferences. So here are some of our future directions, like wound mapping, developing national international wound care training program, and also to launch a mobile app. So this app will automatically measure the wound size, condition of the wound, and it predicts the wound healing time also. So in summary, the wound care nurse will bridge the gap between the faculties and residents, as well as she is a bridge between the all other departments. So she ensures the wound healing by bridging the gap. Thank you.
Thank you very much, Vanilla, with such a elaborative talk on the critical role of wound care nursing. And I must admit that at JPNHC, in our soft tissue injury patients, we are having outcome at the level of international standards. And that major contribution goes to Vanilla and his team of wound care nursing. And probably she is having much more, I would say, more information and knowledge about the wound care rather than my residents and me as a faculty. Thank you very much.
Sir, thank you so much, sir.
So before proceeding further, if there are any questions, we can take up just 1 or 2 short questions from the panelists. Otherwise, I would request Dr. Suresh to invite our next speaker, please.
We are privileged to have a young and dynamic nursing professional with us, Dr. Rajesh, who is Associate Professor at College of Nursing, AIIMS Rishikesh. And I was privileged to work with him for quite a significant time, being principal at College of Nursing, AIIMS Rishikesh. He had special training in trauma nursing, and he had been faculty teacher for undergraduate and postgraduate students for trauma nursing at College of Nursing, AIIMS Rishikesh. He had made international visits to learn and teach at Singapore and Baltimore, US for trauma nursing. We have Dr. Rajesh to speak today on trauma nursing care in India, future needs of trauma nursing services in developing countries. Dr. Rajesh, we welcome, and the stage is for you for next 20 minutes.
Hope my slide is visible, sir.
Yeah, Dr.
Yes,
Rajesh,
we can
you
see.
can continue, please.
Thank you, sir, for such elaborate achievements and introduction. You are always been a mentor and guide for all of us from here also and from that place also. And we always inspire by your academic excellence, and we are trying our best at this place. So it's a very late good evening right now because the things are got delayed in between. So I will quickly talk about trauma nursing care in India, future need of trauma nursing services in developing countries. So while preparing this session, I was seriously thinking about 2-3 things that why does some of developed countries like US, Australia, and New Zealand doing better in trauma management? Is the investing huge money on high cost equipment and high-end technologies worthwhile? Or there is something else for substandard trauma care and management in developing nation, including India, as well as China and many other like Bangladesh and many other countries. You will get the answer of these 2-3 questions in between the talk, and I will let you highlight. So let's see how the trauma nursing has been evaluated. So yes, I am, as Dr. Sharma said, I privileged to visit this trauma center, Idam Kavli Shock Trauma Center, Baltimore, USA for 2 weeks as to get a training of orientation and to start up trauma center at our place, since it was in the beginning stage, but now it is very well established and working well. So 2 nurses, Elizabeth Scanlon and Jane Tarrant, they were the first trauma nurses, and they set up an example of high-level physician and nurse collaboration with equal responsibility in trauma management. So basically, when we talk about trauma, it's not about that nurses are more important or doctors are more important. It's basically work or come as a team. When you work as a team and when you work in a good collaboration, there will be good output start coming. And they highlighted a couple of nursing role in trauma, including like continuous monitoring is required. We know about that relationship of mechanism of injury with the output or subsequent complication, physiological and psychological response to trauma by trauma victims, and importance of restoration of body function. So the role of nurses are very vital and very key in trauma management and trauma care, and we have to understand it at this level. This is high time. So what trauma nursing basically means for us? So in Western countries, when we talk, trauma nursing started long before, and some of the countries are doing very well, like in US, in Australia, in London, and in Ireland. Many other countries are doing very well. So they are highly specialized body of knowledge. Nurses, they are having PG degrees. They will help to understand mechanism of injury and the resulting pathophysiological response to insult. Attend an exhaustive education and rigorous training protocol. Definitely, they will go through a training that more or less, to our residents or our, consultant, what they work in the trauma setup, often involving care of people with critical and life-threatening injuries. And that is very difficult job, since they are in the 24-hour duty, 365 days, and they know the progress. And when we visiting the, shock trauma center, I was so overwhelmed with the response of the doctors or the consulting physicians, that they are taking whole progress of the case from a nurse who is there as a RN, and they are making the decision, not making the changing of decision of protocol based on the response of the RN. So the role of RN was quite more in that setup, and that should somewhere we have to inculcate in our setting as well. So when we see the characteristics and functions, so in the right side of presentation, you can see the characteristics that they are one of the most intense, fast-paced profession in healthcare. Multidisciplinary team of trained experts. There are different kind of trauma nurses are there, including trauma nurse coordinator, ICU nurses, and many other trauma team like ACLS, Code Blue, many other type of nurses are there. These fearless nurses care for the patient with life-threatening injuries from work accidents, physical, violence, burn, and crashes, just to name a few. Favorable outcome are well documented of a designated trauma team. As I discussed, that nurses are not only important. When we talk about the favorable outcome of a trauma team, it goes to a teamwork, that how physician and nurses and many other people like paramedics are working together for saving a life of the patients. primarily focus on resuscitation and stabilization of the victim. So that is the main role. Though before resuscitation in pre-hospital care, their role is also very well documented, and we'll discuss about that. So basically how they will function. So they will start from the first aid, like in paramedics, we have seen in a developed country like Singapore, they have trained paramedics, trained EMS, that they will have a diploma of 9 months, and they know how to stabilize the C-spine, how to give the first aid, how to stop bleeding, how to correct the pneumothorax at the site. And once the patient will be settled, they will bring the patient, and they will have a dedicated checklist, and that checklist, while transferring the patient to the ER or trauma center, they will give what they have done and what is left. And they will do the CPR, they will care for the wounds, administer IV fluid, blood products, emergency medicines, reassure patient, family member. Yes, this is very important actually. In our setup, we will take care of the patient, but we left over the families. We'll never update them about the status of the patients, that what is going on the patient, what condition the patient is right now, and whether it is improving or deteriorating. So family member always, in the situation of anxiety, and they will feel confused, and in some sort of situation, they will work seamlessly with the team of medical team, work with law enforcement to report cases of abuse or criminal activity. That is also very important, because in maximum trauma cases, we have some sort of role of legal issues, and that has to be reported. Now, when we talk about trauma team, so I think we are all has gone through this experience, that we know about that there will be a trauma team leaders, there will be anesthetist, surgeon, general orthopedics, emergency physicians, and 2 nurses at least. But there will be a separate nurse, trauma nurse coordinator, as well as CRNA in case you don't have anesthetist. So CRNA role has to be devised in our country, as it was discussed by Professor Sharma as well, that few roles are very much required in country like India, and that has to be developed, and this is the high time to develop those cases, because the role of CRNA is equal to anesthetist. And in shock trauma center, we have observed that out of 12 OR operation theater, there was only 1 anesthetist, but every OR having CRNA. So they are playing the role of anesthetist, and for this rigorous training they have completed, and they got certified, they got licensed, and they are working well. And radiologist, including radiographer and these blood bank, and many specialist surgeon, whichever is on call, like neurosurgeon and many other CTVS, and many one as per the need of the patient. So here also we can understand that role of nurses, which are trained for trauma care and trauma management, is equally very important, and that has to be understood by us. When we see that this is organized trauma care basically. So I was talking in the first slide that why we have unfavorable outcome in our country. If I will say there's some sort, like we have a trained manpower more or less in few of the trauma centers, like Delhi AIMS Trauma Center, B2 also trying, AIMS Jodhpur also trying, like this many other state medical college, many new AIMS also trying to train their manpower, but still our trauma care is not organized well. So this is basically a flow chart that will help you to understand that what should be mission, that you should have 24/7 trauma services, and your staff should periodically go for education training, and a seamless research has to be conducted. You should have an infrastructure available. You should have a trained team, resources in terms of protocol, expert, air ambulance, and then you can expect, yes, survival rate is improved and there is less negative outcome. So this dedicated organized trauma care is somewhere missing in our setup, and that has to be streamlined, and that has to be put on the floor, and then we can expect that there will be some positive or expected outcome. Now, when we see the role of nurse in pre-hospital care, so as I discussed, in developed country like US and UK and like Singapore and all those, in New Zealand and Australia, there will be a dedicated team of paramedics or EMS. In our country also have the EMS system alerted, but it is not working well, and somewhere we can see that staff, whichever is appointed for that EMS team or paramedics, like 108, that is not trained and not educated well. So they do not know how to give the first aid itself. I should not talk beyond that because first aid is the initial thing. If I will talk about cervical immobilization or relieving pneumothorax or many other stop bleeding, wound care, these kind of things, they are more or beyond the imagination in our country. But at least if they get a training of first aid, that can bring a lot many changes in trauma care and survival or improving the negative outcomes. But this has to be put into the place. This has to become into the documentation. There should be some certification for those people who are dealing with the EMS or paramedics. Now there is a dedicated role of trauma nurse, like they will receive information properly while receiving information from injury site. That is very critical because you will get the disconnected information, and you have to understand, being a experienced and trained staff, that what kind of injury is expected and who has to be sent with what resources. So ideally, what ambulance facility we have, that is not up to mark. What facility is there in the developed countries, it is there, like we can see that air ambulance in our country, it's started in very few places. But in Western countries, almost all countries having multiple type of air ambulance facility, they have trained this air ambulance nurses as well. They will shift the patient, they will transfer the patient. But our country, this is somewhere missing. Then trauma team activation is another thing. As I discussed, the concept of trauma nurse coordinator is missing in our country. That has to be activated, that there must be a dedicated trauma nurse coordinator, and he or she will activate the trauma team, and he will brief the trauma team about the expected injury, about the expected time of arrival of the injured patient or casualties. And ED and trauma bay preparation, that is also one more important function. Taking over from emergency medical services when paramedics are handing over the cases, and that is very important. What they have done and what is left over, that has to be done by the ED team or experts. Reporting or briefing to the team leaders, triaging, transfer to the right areas or triaging, documentation, and reporting legal or forensic issues. So you can understand there is a dedicated role of the trauma nurse, and somewhere few roles are missing, and I can say it is not organized well, and we have to start working to organize it. Though we started working in that, like we have started ATCN training, ACLS training. So somehow we are able to make them trained or make their attitude change about the trauma care, but it should be come from education in the beginning, because you will get in temperament, you will get in attitude change from the beginning. If you will feel like I am going to prepare myself as a trauma nurse, so what kind of exposure I should have. So if it would be there in the curriculum, that can be an added role, and that can make them more specialized and can change their attitudes. Now, core element of trauma nursing. So basically core element will remain same, like education, training, and research. So education about the more focused on clinical case scenario and intricacies of different type of traumas. So that is missing, as we have only 1 or 2 units in our curriculum syllabus, that is in masters. In BSc, this is whole missing, or if it is there also, it is very brief or overview sort of type of units that is not sufficient for them. Then trainings, hand-on trainings, make the nurses more confident and competent to deal with complicated traumas. So hands-on training, we can have alternative like simulated training. We have started also, and that can make them more confident. Initially, we can expose them to the simulation training, and later on we can, gradually we can start involving them into the trauma case management. So this can be possible. Now, ongoing research in trauma help to save unimaginable number of deaths, and this is possible because nurses are very least interested to do research, specifically in critical care area. So that has to be include somewhere. We have to sensitize them, whoever is working into the trauma area, that they will involve themselves or at least associate themselves with the research. What kind of research are going on? At least some sort of attitude change is required, so that they will understand the intricacy, and they will understand the role of research, and they will start doing on their individual basis. So this is again one more thing is required. So when we see the education diversity in India, so we have like operation theater techniques after basic nursing qualifications, cardiothoracic nursing, peri-operative nursing, and many other
such
Dr. Rajesh, sorry to interrupt you. Please be a little bit quick.
Yeah, some sort of certification. But in masters, like we have critical care nursing and cardiothoracic, but master in emergency and trauma, it is in pipeline as discussed by Professor Sharma. And diploma in forensic nursing already syllabus is implemented, but there is no takers. So specialty trauma certification in nursing is required depending on where you work. You might be required to get additional certificate, emergency nurse, pediatric course, especially the trauma nursing core competency, certified flight registered nurse, certified emergency nurse, and certified transport registered nurse. So your area will decide in which area you are working. As per the need of that area, you can be certified, and for that some certification and some licensing process should be there. Now, as I was talking, there are many universities which are in the Western countries, they are providing, training in the trauma or emergency. These are some university I was quickly able to find out, and we can follow these university, or we can take as a benchmark, and we can start processing our things. Now, trauma nursing in developing nation like China. So there is not much difference, no formalized and coordinated trauma system, nor has a mature national level trauma registry, no official recognized paramedic profession. Whosoever is paramedics, either they are doctor or nurses, but they are ordinary doctor or nurses. They are not specifically trained for paramedic. There is no proper communication information for pre-hospital services. That is also there in our country. Only road ambulance, no air system, since it is high cost. However, many hospitals start establishing trauma center in the China. So there was a research like in 2008 to 2017, around 10 or 11 year research, they highlighted that more resources and efforts should be devoted to pre-hospital EMS for pre-hospital EMS demand and prolonged emergency response time. Now, post-resuscitation and rehabilitation challenges in China and India, there is lack of integration of trauma and other departments. We can see like specifically major department like orthopedic, neurosurgery, these are lacking somewhere in integrity, and that has to be come up. Lack of trained paramedics, no formalized trauma system, and only level 1 and 2 trauma center attached to medical and super specialty center, though now government initiated to upgrade the medical college to trauma 1, 2 and 3 center. Pre-hospital are not up to mark. As I was talking, 108 ambulance that has to be upgraded, not having any organized model of trauma rehabilitation. So far, it is missing from our system, and that has to be added somewhere. Now, future of trauma nursing, as I discussed, we started a couple of things like air ambulance facility. We started ACLS, ATLS, ATCN, Team Code Blue, and recently the very first course pre-hospital trauma life support is started in AIMS Rishikesh, and hopefully other AIMS will also follow. And some of the courses are in pipeline, and we will start implementing those, and will start soon. When we see that future of trauma management need robust trauma services, facility, resources, and awareness on top of that, identification of accident black spot by Ministry of Road and Transport, compliance to National Road Safety Policy, that is very much required. Emergency medical services for roadside assistance, specifically for rescue, first aid, and transport, and capacity building and preparing more trauma nurses. This job is taken care by STN, and luckily we are able to take it up to the next level, and we are start training our trauma nurses, and we are doing better than earlier. Use of simulation to train nurses is need of hour, and that's all new aims, I think. And Delhi AIMS is also started, and more trauma specialization on Western scenario that is also required. So some of the courses started, maybe in the future, some of the things will come up, and they will also start. So government also has taken initiative. Government set up trauma care facility every 100-kilometer radius along the national highway.
Rajesh, please sum up. We have to wind up.
Yes, sir.
Please.
Only 1 or 2 slides, sir. Guideline on capacity building for trauma cares, and we are celebrating every year World Trauma Day for creating awareness on trauma and road safety. So take home message: to meet this colossal challenges, trauma nursing can play a vital role, and organized pre-hospital and trauma care are the need of hour, and we have to look into that. More specialized trauma courses after basic nursing education is need of ours. Public-private partnership in trauma management and support is also one essential components. So with this, I would like to thank to the organizing committee for calling me as a speaker and allowing me to share the experiences. Thank you very much.
Thank you, Dr. Rajesh, for such a informative talk on the status of the trauma nursing across the world.
So if panelists have any queries with the Dr. Rajesh, we can take up.
I think it was a nice presentation done by all the speakers. I just request Dr. Dinesh if we have any questions in chat box.
No, sir. So far, we are not having any questions there.
Already we have overshooted the time. So if there's
Yes,
no
sir.
questions, we can wind up. We hand over this to the moderator. Thank you so much.
Thank you, sir. Thank you very much. And I extend my gratitude to all the respected chairpersons and speakers for taking their time out and devoting us for this conference. And it is always, feel good when you have a part of your team beside you. And as far as the trauma is concerned, as Dr. Rajesh said, it is not the who is playing the role. It is the role of the team towards achieving the cumulative goal of getting best possible outcome of the patient. And that is what all about trauma management. So thank you very much, all the faculties, chairpersons, and listeners, delegates, for devoting your time, and have a nice day. Thank you very much.
Thank you.
Thank you, sir.
Thank you so much.
And
Bye-bye.
we call it a day.
Thank you, sir.
Yeah, thank you. Yeah, tech team, we can close the session.